event where all the lectures are being recorded live and then edited for HR, and then broadcast live. I mean, not live, but they're stored on the internet, so you can watch them on YouTube. Everything you saw yesterday, if you want the slides, everything is there. So first speaker for the session today is cardiogenic shock. And the first speaker will be Omar Saeed, who is one of the attendings in our group, who is really a true expert. The lecturer will be incredible. He's also the director of our ECMO program, together with Mayuko Uehara, the cardiac surgeon that will speak later on. Omar is currently NIH funding with a K23 grant from the NIH, and any day now, it's going to get a score on an R1. For those of you who don't know what that is the ultimate award you can get at that level of your career after the K grant, which is the ultimate early grant, and it's about $2 million. So we're hoping that he gets that and can pursue further research in mechanical support. But firstly, we'll give us an overview over cardiogenic shock, where the field stands, to set us up for hopefully very good debates. Thanks so much.
Good morning. Thank you, Uli, for that introduction. So this talk is titled State-of-the-Art Diagnosis and Management of Cardiogenic Shock. Is danger shock a game changer? Here are some of the disclosures that. So before we get started, we'll do this ARS question. So a 68-year-old woman presents with acute MI cardiogenic shock despite catecholamine support. En route to the hospital, she was resuscitated after VT arrest, the ROSC in 3 minutes. In addition to culprit lesion PCI, which temporary MCS device is your first choice? So a balloon pump, an Impella CP, VA ECMO, or just need more information?
You have to swipe it. Just go this way.
Get some of the loading. Okay, didn't want to give a bit of a softball in the beginning, but great. So there is a purpose to this lecture. You do need more information before we decide this answer here. Great. Want to just do it here? Okay, this is the second question. So a little bit more of a specific answer here. But what was the median number of days that the Impella CP device was in place in the patient in the danger shock randomized control trial? Was it 1.5 days, 2.5 days, 3.5, or 4.5 days? Great. All right, so there's some parity here, either 2.5 or 3.5. All right, as we go through the presentation, I think the answer will become clear. Okay, now taking a step back here, what is cardiogenic shock? So it's not as simple as the word sounds. It's not just low output from the heart and low blood pressure. There are actually specific criteria for this, which have been used for the clinical trials that we'll go through. So the first element is hypotension. Obviously, blood pressure has to be low. And this is specifically a systolic blood pressure less than 90 for about 30 minutes, or requiring use of drips, vasopressors, and inotropes, or even a temporary device to maintain this blood pressure. So that's one element. But in addition to hypotension, there needs to be hypoperfusion. A lot of times patients have heart failure and they're not hypoperfused even if their blood pressure is low. So for cardiogenic shock, you need hypoperfusion. And this is evident by possibly low urine output or an elevated lactic acid, and that's been defined as over 2. In addition, we need some information of hemodynamics beyond this blood pressure. This will require a PA catheter. So intracardiac pressures need to be elevated. specifically a CVP over 10-15 and a wedge pressure over 15 to 20. So those need to be up. And lastly, the cardiac output has to be reduced. And this is defined typically as a cardiac index. So it's normalized to the patient's body size of less than 2.2. When all these four elements are met, then the patient actually is in cardiogenic shock. So again, beyond just low blood pressure, low EF, this is a clinical diagnosis. What is the epidemiology of this disease? So this is the problem here. It's rising. So these are data taken from the nationwide inpatient sample, which captures 20% of the US hospitalizations. And you can see over time, this is from 2004 to 2018, the different lines are different types of cardiogenic shock. But in blue, it's just all CS, and it's rising. So the incidence is going up with time. More patients are having these sort of MIs that are being complicated by cardiogenic shock. Patients have a history of heart failure. They're presenting in cardiogenic shock. So this is on the rise. If we subdivide it into those with an acute MI in yellow, or those with non-acute MI, so about half the patients don't even have an acute MI. So even both of those subgroups are on the rise. And then what about during STEMI? So even in that situation, the incidence of cardiogenic shock is on the rise and occurs in about 10% of the patients. But these are the patients that actually don't do well during MI. And here are the mortality numbers. Again, the same registry, that nationwide inpatient sample. So you can see here the mortality, the inpatient mortality, just the chances of the patient getting out of the hospital in the index event is not good. So for cardiogenic shock in blue, this is about 40%. So 40% of these patients are not going to make it out, which is very alarming. This was a little bit noted in the prior slides, but typically cardiogenic shock is thought about an acute MI and then it's complicated by shock, but many times it's not that. A lot of the times it's also an acute or chronic problem. Patient just has a baseline cardiomyopathy and then they decompensate and escalate into shock. And in addition, there are other etiologies such as arrhythmias and several others. So it is important to understand, of course, the etiology, because in addition to stabilizing the shock, we have to address the specific etiology, which may not be just coronary related. Now, I thought this study was interesting. This is a new study that was just published by the Cardiogenic Shock Working Group, which is an international registry of up to 10,000 patients now. But this study had about 5,000 patients in it. And it actually shows a disparity in outcomes by sex. So women that present in cardiogenic shock tend to do worse as compared to men. And why is that? So this paper then went on to look at potential reasons for that. And you can see in the middle there that there are more complications experienced by women when they're in cardiogenic shock. And these include more vascular complications, more bleeding problems, and as well as greater limb ischemia. And the other part I thought was interesting, unfortunately, the advanced therapies that are used in cardiogenic shock, such as LVAD or transplant, are actually less commonly offered to female patients. So I think all these factors contribute to this gender gap you have as far as the mortality of cardiogenic shock and requires further study. Now, stepping further back into some of the data that's out there and how do we manage patients in cardiogenic shock. So there was this shock trial. This was done many years ago, about 2 decades. And this was taking patients who presented with acute MI cardiogenic shock and randomizing them to revascularization or medical therapy. In the trial, the endpoint was at 30 days. And although the curves separate, that actually was not statistically significant. But then there was a repeat publication for longer-term follow-up at 10 years. And eventually it was recognized that those who did have early revascularization actually did better compared to just medical stabilization. But the alarming thing here, you can see that even though they did better, but both arms have very poor outcomes again. And the longer-term data are more in the contemporary period. And it's very alarming that in either arm, way more than half of the patients still don't survive. Moving forward, there's some more recent data as far as the revascularization management in these patients. So this was the culprit shock trial. This enrolled patients in acute MI cardiogenic shock, and they were randomized to culprit lesion-only PCI versus multi-vessel PCI. And it was evident here in the setting of cardiogenic shock, it's better to just intervene on the culprit lesion rather than trying to fix all the other things in the coronary. So the patients that had culprit lesion PCI had lower mortality, and that was also evident just with death or a composite endpoint. So this was important information as far as management in acute management to just go after the culprit lesion. But beyond just PCI, again, if you look back here, the mortality is still elevated, even if culprit PCI is done. So what is actually going on in this situation, right? If the EF is low, there's low cardiac output. It turns out that this, in those patients that proceed to cardiogenic shock, kicks off a cascade, which becomes very difficult to control unless it's really recognized very early on. So there's low cardiac output, hypotension, reduced systemic perfusion, higher lactic acid levels, which in turn then leads to vasodilation, reduced coronary pressure, perfusion pressure, furthering this cascade. And eventually you start getting into these things like inflammation and higher cytokines, higher nitric oxide levels. And once all that starts, there's a lot of end organ damage that happens. And then no matter what you do, whatever device, whatever pharmacologic measures, the patients don't survive. So it's really critical to recognize this process very early when the interventions are much more helpful. We talk a lot about the epicardial vessels and the macro circulation. It turns out in cardiogenic shock, there's this whole hidden problem of the microcirculation. Because you can imagine, well, we'll stabilize the patient, we'll put them on whatever MCS device, restore their cardiac output. Oh my God, the patient still didn't do well. What happened? The cardiac output was okay. They were perfusing, but didn't work. This part of this has to do with this discordance that happens. In the beginning, when there's macro circulatory dysfunction, PCI is done and maybe a device is placed, great. But if that process is not recognized early on, and there is onset of end organ damage and microcirculatory damage, then there's this discordance that happens when even if the cardiac output is restored, it doesn't matter because the small vessels have become lost their integrity and sustained a lot of damage. And then the mortality becomes very high. This picture here is just one image of the microvessel. This is sublingual vessels. You can see in control versus during cardiogenic shock, the microvessels really lose their integrity. So very important to recognize the problem early on and then restore perfusion very early before this happens. This study also just recently published, and I thought it was interesting just to further understand this phenotype of cardiogenic shock. So not all, we defined the 4 elements that make up cardiogenic shock, but after a person is in it, they can still diverge into different phenotypes. So this was data, again, from the cardiogenic shock working group and 2 other cohorts. You can see the sample sizes there. And they actually they had a lot of clinical characteristics, and they fed all this into the computer, used the AI algorithm to see how the data could be separated and which clusters it was separated into. And ultimately, it was separated into 3 different clusters. So there is this non-congested phenotype where the patient is in cardiogenic shock, but they have not terribly high filling pressures. Then there's a second phenotype of a cardiorenal syndrome happening where the creatinine is going up, urine output is coming down. And then there's the third phenotype, where this cardiometabolic phenotype, where a lot of the end organ damage has already started to happen. The LFTs are rising, lactic acid is high. And as you can imagine, regardless of which cohort the data was from, the phenotype in the blue had highest mortality. So this reconfirms this idea that when there is, some of this is intuitive maybe, but it again highlights the importance of recognize this in real time because these things do affect mortality. So to help with this, there's the SKY criteria that's come out recently. And this is just to, again, help us recognize this diagnosis, this cardiogenic shock process that's starting to happen. So this is broken down into 5 categories. So category A are those people that are at risk for developing cardiogenic shock. Then B, which is the beginning of the shock process, but there's no hypoperfusion. So here the lactic acid may still be normal, but it's important to check it. And then there's the C portion where now we're starting to see higher lactic acid levels, some end organ damage happening. Here, this is very important that this part is recognized and ample support is provided so that end organ damage doesn't continue to happen. Some argue that it's even important to place these devices early on, even in the B phase. But of course, before any of that can happen, you have to know if it's actually going on. And once this progresses into the D and E portions, the mortality goes up exponentially. And one thing also this shows us beyond just recognition of cardiogenic shock is the dynamic nature of it. this is not one of those diseases, I think, that's just managed in the cath lab, like snapshot, cross-sectional management. It doesn't, this process is dynamic. Stabilization happens in the lab, and the patient goes on into the CCU, and a patient can be in flux. They can worsen or they can get better. But the job of the team that's managing the patient is to recognize if the patient is actually worsening and do appropriate intervention. What about pulmonary artery catheters? So, the ESCAPE trial was performed in patients with decompensated heart failure. This is many years ago, and it was not a good result. The patients that received PA catheters had a lot of side effects. So there's much talk of abandoning this PA catheter use, but you have to understand that was not cardiogenic shock. Those were patients just in decompensated heart failure. These are two different things. For patients in cardiogenic shock, the cardiogenic shock working group looked at the association of PA catheter use and mortality. So these are, again, retrospective data, but multi-center. And they divided their data groups into three different cohorts: those that had no PA catheter use, those with an incomplete assessment in red, and those that had full hemodynamics. And you can see what in the overall group or different stages of SCAI, the group that had a full PA catheter assessment was associated with the lowest mortality. Now, you can argue maybe those were the most stable patients. It allowed time to get all this assessment done, which is reasonable. It's a retrospective study, but there is an association, at least, if we understand the hemodynamics, perhaps that may influence the mortality. Now, to really look at this in a more standardized manner, a randomized control trial is going on, which will randomize patients in cardiogenic shock to initial PA catheter or no PA catheter, and then we'll see that affects the outcome. Now, moving forward, I talked about the phenotype of cardiogenic shock, but within that, there's actually the hemodynamic phenotype. And this is really important to understand because it will help us determine which intervention to use and how it's changing. So a different intervention may be useful like the next day. And this has to do with interpretation of SWAN-related hemodynamics. So I'm going to go through this. So these are 4 different patients. They all have a low blood pressure. They all have reduced LVEF. But just by looking at the blood pressure and the echo, we don't know what their hemodynamic phenotype really is. And that's going to become more clear as we look at the numbers. So in the first case, this is a patient whose RA pressure is 10. They have a high left-sided pressures, wedge pressure of 30, high PA pressure. A lot of that is just coming from the left side, and a low cardiac index. So that's one set of hemodynamics. A second patient, here the pressures on the right side are elevated. So the RA pressure is 25. The PA pressure is actually low. The wedge pressure is low. The cardiac index is similar to the first case. Then you have a case where the intracardiac pressures are elevated on both sides. The RA pressure is 25, wedge pressure is 30. Again, the cardiac index is low. And lastly, this patient is on 2 drips, on levofed and dobutamine, and also has biventricular elevated filling pressures. So 4 different patients, all with low blood pressure and low cardiac index, but within the heart, different hemodynamics. But if we use these numbers, we can really understand that they're having different processes of cardiogenic shock. So if the first patient is really in an LV failure, and the next one this is more of an RV picture, and then there's biventricular failure in the third case. And lastly, the final case, which is actually a very common way these patients tend to present now, is a mixed picture of cardiogenic shock and vasodilatory shock. This is important to understand, again, because it will drive the appropriate intervention. If we don't know these numbers and we just look at the blood pressure and the cardiac index, we're not really going to know, which pharmacologic measure to use and which temporary device to use. So how are these patients being managed nowadays? These are data taken from NCDR, which is a large registry. A lot of the data just comes from patients that present, with acute MI shock. So this was recently published in JAMA. So in those patients that have acute MI cardiogenic shock, you can see the graph on the left that about more than half of them are just being managed with medications. So that's the dashed line, right? Medical therapy only. The line below that is still balloon pump. So when a device is being used, most of the patients still are getting balloon pumps in the US. And then finally, you see a bunch of cluster lines, which is then magnified in the other graph. So again, the top line there is balloon pump, but then we see this other line that's starting to creep up, and that's the use of these intravascular microaxial LVADs, which is the Impella device. So that over time is starting to creep up, you can see there. So once we use pharmacologic measures like dobutamine, but it turns out the patient's perfusion is still poor, or they're having arrhythmias and inotropes are just not an option, then it gets into this whole phase of temporary mechanical support and which devices are available. And that's where that hemodynamic phenotype is important to know, to really know which device to use. But in the toolbox of MCS, there's balloon pump, there is ECMO, which can be placed peripherally. Centrally is more in the patients with post-cardiotomy cardiogenic shock. And then, of course, the Impella devices, and they come in several types, the CP55 and the transaortic version. There's also the durable LVAD, HeartMate 3. Now, it's very difficult to take a patient in acute MI cardiogenic shock all the way to the operating room. So that option is not utilized very often. And now moving forward to the right-sided devices, such as the Protect Duo. And there's a CenterMag device, which can be configured both as a BiVAD or just an RVAD. So a number of devices that can be used, but which one to apply, it really depends on the hemodynamics. And other factors in addition, so the degree of support, so this goes back to that first ARS question. This is why we need more information. So the degree of support, the patient is on several drips, like that final case in the hemodynamic phenotype on dobutamine and vasopressin and levofed, they're already on a lot of pharmacologic support. It's not going to make too much sense to put in a small caliber device like a balloon pump. It's just not going to be enough. And of course, vascular disease. These are large bore devices. If they're put in patients that have a lot of vascular disease, a few hours later, there's going to be limb ischemia. So that's an important component to consider. As the Impella devices are used more often, we really need to know if there is a thrombus in the ventricle, because that, if it's not recognized, and this is tough, there's a lot of stuff happening in the acute presentation, but one thing that is important to know, there's a clot in the heart. If there is, and the Impella is put, I think it puts the patient at a higher risk of having a stroke. If there's a mechanical aortic valve in place, that's going to make it tough to put an Impella device in the patient. We talked about the cardiogenic shock phenotype, the hemodynamic phenotype, which is important to recognize. And of course, the comorbidities of the patient. If patients have end-stage other disease, end-stage cancer, or if their platelet counts are just very low, there's some other process that's going on, then using these sort of temporary devices is most likely not going to change the prognosis. And finally, when these things are being considered, it's important to know what is the exit strategy. These are temporary devices that just buy us a little bit of time. So it is important to understand, what is the downstream way we're going to finally stabilize the patient if they don't improve with these temporary devices. Now, we finally have randomized controlled trial data during temporary MCS use. Some of this of course, came out a few years ago, but this year, there has been further advancements. I'm going to go through some of these trials, which I think are important to understand as we are applying these devices. So one of the studies was this IABP Shock 2 study. This was actually published over 10 years ago. This took patients with acute MI cardiogenic shock, and they were randomized to balloon pump or control. So these are some of the baseline characteristics. I'm showing these because we're going to see as more trials of acute MI cardiogenic shock are done, it actually turns out there's a little bit of a different population that's being enrolled as we learn this problem. It's not like all shock is created equal. So in this study, these were the major characteristics. I just want to point out the lactic acid at presentation was about 3.6 in the balloon pump group and a little bit higher in the control. This is important to consider. So patients that have had cardiac arrest or resuscitation prior to randomization was about, almost half of them in the control group. It's very high. And we'll see as the more contemporary trials are done, we're starting to understand that if the patient has had a cardiac arrest, they're really falling into a different group of patients. Okay, so in this study, what were the outcomes? It was a neutral study. So at 30 days, the outcome of death was the same in the patients that either got a balloon pump or were on control. And again, you can see in both arms, the mortality was about 40%. Further adverse events were also tabulated in the study, and these are important to see and compare to more current studies. So in the patients that had a balloon pump, the rate of stroke was actually very low. Only less than 1% of the patients had a stroke, and in control was a bit higher, actually. And of course, bleeding. So these patients are on anticoagulation, antiplatelet agents. So the bleeding, the moderate or severe bleeding was about 20% in both groups. But based on that data, there's a lot of talk, well, balloon pump didn't make a difference, so then forget it. It's not going to do anything. It turns out it's not so simple, because there's actually a subset of patients. This is data that was published, a sub-study of the shock trial, where those patients that responded to the balloon pump that had improvement in their hemodynamics actually had a better prognosis. So there is a subset of patients that may respond to balloon pumps. And Francesco, who's sitting here, and he's joining us as faculty, as a fellow, he'd done this wonderful study where we took all our patients with acute myocardiogenic shock and longitudinally followed their hemodynamics and looked at which were the predictors of this response. And these were some of the factors that were isolated, like body surface area and having actually a better cardiac index at baseline. Now, moving forward, this is kind of the prime time study that's out there this year. This is a major advancement in the field. And I think it's important to go through the study because this stuff is applied like day to day now. So this is the dangerous shock study. So in this study, this was just patients with STEMI and cardiogenic shock, and they were randomized to the Impella CP, the microaxial flow pump, or standard of care. One thing to note here, this trial took a while to complete, over a decade. And one of the reasons that was the case, as you can see here, many patients were excluded from the study. So the trialists were very careful in selecting patients who they felt would actually benefit or there was equipoise to randomize them. So you can see some of the reasons people were excluded. So the one that jumps out right there is cardiac arrest. So those that had a cardiac arrest were comatose were not included in the study. And many other exclusions are listed there, including frailty and some logistical problems. But finally, they narrowed it down to a randomized population of 360 patients, and then those were randomized. And at the end, the intention to treat population was 176 and 179 in the Impella arm. So these are some of the characteristics of these studies, of this patient population. So one thing that jumps out right away to me is we see here that not every patient that had a resuscitation was excluded, but the population, though, that had a lower number of resuscitated patients in IABP shock 2. So here, only about 20% of the patients had sort of resuscitation before randomization. And the serum lactate level, so this is similar to the balloon pump study of around 4.6. This goes to that second ARS question we had in the beginning. So the device was only in place for 2.5 days. We'll see the endpoint of this study is 6 months. So there's something that's happening in the first 2.5 days that has the ability to impact the outcome in 6 months. So I think that's an interesting thing. And, we don't think about the Impella being in for 2.5 days. Usually the device is in for longer than that, especially if the patient is transferred in. And this is also another important thing. The patients in the Impella arm, more of them had a permanent device like a HeartMate 3 LVAD put in. You would imagine that this would be possibly equal, but there is a bit of a difference in the post-randomization management of the patients because more patients in the Impella group had a HeartMate 3 durable device. So these were the findings of the study. So the patients that were randomized to Impella in the orange color there had a better outcome. So fewer of those patients died at 6 months compared to the standard of care arm. The hazard ratio was 0.74, which is really good. It actually leads to a number, the absolute difference in the two lines leads to a number needed to treat of 8, which is fairly low. But I think it is important to still point out, this confidence interval is 0.99, the upper limit. What that means is that even if 2 patients had crossed over and had a different outcome from each arm, at least statistically, the findings would not be significant. So this is a fragile finding. What that means is that it probably needs even more confirmation. But for what it's worth, though, this was a positive study. And again, also positive in the secondary composite cardiac endpoints. One thing to note still, though, even in the Impella arm, the mortality is still very high. So even if you got this thing, which helps, a lot of the patients still didn't survive. And this is a very important slide. We have to look at what adverse events are happening as this device is used. So right off the bat, you can see the composite safety endpoint was much higher in the patients that had an Impella, like 24% versus 6.2, so 4 times higher. And then if you break it down into different components, there was a major bleeding in about 20% of the patients. One concerning finding is stroke. So about 4% of the patients had a stroke in the Impella, and this was higher than in the control group. Honing a bit down to the subgroups in this study, so this was not designed to detect subgroup differences, but nonetheless, the authors showed this analysis And it's important to see that in female patients, there was the point estimate is neutral. Now, this wasn't powered to detect differences, again, between sex, but the male patients were the ones that really saw the benefit. And another interesting thing here is those that had a lower MAP, less than 63, are the ones that really got benefited from the Impella. This points a little bit towards, sicker patients, perhaps the device is being worth considered even more so, and not that every patient in cardiogenic shock ought to be getting this device. Again, I talked about that how the findings are a bit fragile because the confidence intervals is almost, the upper limit is close to 1. So there is another study that's going on currently in the US, the RECOVER-4 trial, which is a similar study, but we won't find out if in the US population, if it shows the same findings. Now, moving forward, other than the Impella CP device, there's another type of Impella. Dr. Goldstein talked about this yesterday. This is placed in from the axillary artery in the arm. And this can also provide a lot of support, a lot of hemodynamic support, but it's really placed in the operating room. It's difficult to place this device in the cath lab. But there's a registry out there now by the FDA that shows us a bit of the outcomes of the Impella 5.5 device, which is the one in use, compared to the 5 device. And there were some modifications that were made in the 5.5. It doesn't have a pigtail. It's a shorter motor and more rigid. So this is the data. These were the demographics of the patients in this FDA registry. So one thing, that's you can see the age and sex demographics of these patients. But one thing that was good is you notice at the bottom here is that there was most of the patients were able to get the device. In over 95% of the cases, it was able to be successfully deployed. Now, more interestingly, what about the outcomes? So, these are selected patients, not a randomized study. Perhaps the investigators felt that they were appropriate candidates for these devices based on the anatomy. But even in this and across the different categories of acute cardiomyopathy or post-cardiotomy shock, about 70% of the patients were successfully weaned from the device and 30% died. So this is lower than that 40% mortality that keeps coming up. So there is some signal, at least, that the device may be helpful. And one thing I thought that was really interesting was the adverse event profile here is actually much more forgiving than what appears in the danger shock study with this device. And lastly, the number of days. So we talked about 2.5 days for the CP device. Here, the 5.5 is in place for close to 2 weeks. So this is, compared to CP, this has greater durability. Now, there's a study going on here, and MonteHeart is part of this study, is the IMPACT trial, which is a single-arm study in patients at risk for post-cardiotomy cardiogenic shock to get this Impella 5.5 put in. And then we'll learn, the adverse event profile in more detail and the outcomes as well. So that's ongoing. Switching gears here towards ECMO. So in the past decade, there's been an exponential rise in ECMO. These are data from ELSO, which collects all the cases that are done across about 600 centers. And you can see here, this is just an exponential rise, right? So a lot of ECMO is being utilized. The question is it actually helpful? You can see the outcomes there kind of grossly. About half the patients don't survive. And if it's done during eCPR, the outcomes are even worse. You can argue that, well, without ECMO, they would all not survive. So there's some use to it. But we still need to understand, which patients really may benefit from this. And to help with that, this ECLS shock trial was just recently published. This was just last year. This was done in Europe. And here are the demographics of the patients that were enrolled in this study. These were patients presented with acute MI cardiogenic shock. And, it's incredible they were able to randomize the patients in the cath lab to ECMO or standard of care. So we look at some of the major characteristics. So in here, a lot of the patients have had a cardiac arrest. This is different than the patients in danger shock and IABP2, right? This is now almost 80% of the patients have had resuscitation done. So we know the outcomes are already not going to be so good. The lactic acid levels are much higher. So these patients are more hypoperfused. Now lactic acid is close to 7. One thing to also note, we'll get into this a bit, this whole concept of LV unloading. So typically we want to do this if it's necessary for the patient, but in this trial, in the ECLS group, only about 6% of the patients had LV unloading. So you can argue maybe that impacted the outcomes. Some patients crossed over to ECMO. That's why you see that percentage in the control group. And finally, I know and DR has a lot of expertise in this, but in this study, only one patient in each arm got a durable LVAD. and just one patient that was in the ECMO group. So the use of durable LVAD is exceedingly small here. What were the findings? So at 30 days, there was no difference in the patients that were randomized to ECLS or control. And about half of the patients died in both groups. One thing again to note here is the adverse events. So devices are being utilized, but they do have a adverse event profile. So in this study, stroke was experienced by about 4% of the patients, and about 11% of them had peripheral ischemic complications. Close to 20% again had major bleeding. So these are all these events that need to be further understood and reduced if there's going to be some efficacy from these devices. Moving forward, so do the adverse events actually affect outcome? So this is data from the ELSA registry, and they actually looked at the how common are these adverse events during ECMO. So this is many more patients than that ECLS shock study. This is about 12,000 patients. And you can see these events are very common in the real world too. So there's a lot of cannula site problems, surgical site, if the cannula is surgically inserted, GI bleeding, hemorrhagic stroke, and clots in the circuit, ischemic stroke, and of course, all these then translate into poorer outcomes. So the patients that experience these adverse events have higher odds of having death. To go into how we could possibly try to reduce some of these adverse events, I'm going to just go into this idea of a lot of afterload during ECMO, because that actually may contribute to some of these adverse events happening. This is a schematic of a patient that is on ECMO. So some of the important areas are this preload, this is in the right atrium area, and then afterload as the blood is returned back from the circuit into the patient. So as we turn up the circuit, it withdraws more blood out of the patient. So the preload is reduced within the heart. It goes into the pump, gets oxygenated, and then it's eventually put back into the aorta, which is really this afterload coming back now in front of the heart that's very weak. So it's very sensitive to any afterload. And as it experiences that afterload, there is now the aortic valve may begin to close from these high pressures, which that may lead to stasis in the heart and eventually back pressure into the lungs, causing pulmonary hemorrhage and pulmonary edema. So for these reasons, there's this whole concept of, if this is happening, to put in an LV vent to try to unload the LV so it doesn't experience such high pressures and avoid some of these adverse events. This was looked at, again, in ELSA, whether patients that get an LV vent, do they have at least an association with less adverse events? So the green bars there are just, the use of ECMO, which is again on the rise. But you can see here in the orange, that's the use of LV vent, and this is through Impella. And that's, again, rising in the more current period. And then the data on the right shows the association of LV vent with outcomes. So there was an association with reduced mortality, but yet higher adverse events in the patients that had a vent. Now, this is, again, registry data. We see an association that's favorable, but it could be confounded because it may be that the patients that had the vent or the Impella just got that in the beginning and then got worse and got ECMO. And you can imagine those are probably not as sick compared to those patients that just crashed onto ECMO. So more to study. And there's actually some randomized studies to vent or not vent after ECMO that we're going to help us understand if it helps. Here at Montefiore, instead of trying to put the LV vent in every patient that goes on ECMO, we've implemented this algorithm where once ECMO is placed, we can monitor from some specific baseline measures at the bedside after about a blanking period, 12 hours. So if the aortic valve is not opening anymore, if there is a low pulse pressure or a high wedge pressure, then we advocate for using dobutamine. That may on its own just provide enough contractility so the valve starts to open and the wedge pressure drops. But if it's not happening, so again, it's critical to keep monitoring the patient. If it's not happening, then possibly LV vent is more efficacious. We also looked at, this whole idea of how we can reduce these adverse events during ECMO, because that could be getting in the way of its effectiveness. So there's hemolysis that occurs in these circuits, and a measure of that is plasma-free hemoglobin. It turns out if that hemolysis is higher after the circuit is placed, eventually there's a greater risk of having a stroke in the patient. So we took our cohort of patients that were on VA ECMO and looked at the 3 levels of plasma-free hemoglobin in the beginning, and the ones that had the highest level of 26 to 50, most of those patients had a higher risk of eventually having a stroke. this is just another ongoing study. I showed that cascade diagram in the beginning, where one of the problems that happens downstream is inflammation, and that's a broad term. But the question is, how much of that actually relates to prognosis during ECMO? So one measure of inflammation is this neutrophil to lymphocyte ratio. The reason it's useful is because it's readily available. That can be derived from the CBC. And we looked at all our patients on ECMO here at MonteHeart, and those patients that very early on after ECMO, if they had a higher neutrophil to lymphocyte ratio, meaning more inflammation, versus those who had a lower ratio, and then we evaluated if there was a difference in outcomes. And it did turn out that the ones that had lower inflammation actually had a lower mortality. Now, this is an association, but I think it does maybe signaling that there's room for targeted therapies into inflammation in acute MI cardiogenic shock or other forms of cardiogenic shock that may affect prognosis. Finally, as these devices are being used, there's this idea of these 4 components that are essential as far as device management and optimization on device support. So this has to do with decongestion. So it's not enough that the patient is on support and perfusing. You got to decongest the patient, and with diuretics or dialysis, because if the volume stays elevated, they're not going to be able to recover. The heart is going to remain decompensated. We talked about minimizing complications, which is essential. This whole idea of ventricular unloading, which may also help to reduce wall stress on the ventricle, help it recover, and may reduce some adverse events. And finally, it's critical to still recognize if everything is being perfused in whatever support system is being deployed. Because sometimes what happens is that it's not. The lactic acid is still rising, the inner organs are worsening, and then we need to escalate things. This is a proposed pathway of cardiogenic shock that may be useful. So a lot of this is centered on early recognition and referral to a tertiary care center like MonteHeart here. And then recognizing what is the etiology of the cardiogenic shock. It could be ischemic, could be a non-ischemic, it could be arrhythmic, that's important. Hemodynamics are critical, as we saw in some of the earlier examples, to really understand how to manage it. And use of temporary MCS is becoming a cornerstone in this disease process. And decongestion is, I think, very important to try to recompensate the patient. And reassessment is critical. This is a longitudinal problem, many days of management to weeks, not something that just is taken care of immediately. It's going to be important to how to lower some of the adverse events as we are using more of the devices. And finally, it's important to also assess whether the patient is recovering or not recovering, because we don't want to leave in ECMO or an Impella even for 1 hour more than it needs to be because of this issue with adverse events. So once there's recovery starting to happen, weaning the device and taking it out is also essential. And if it's not happening, we have to think about what is the destination for this patient. So some of that is also in this slide. I showed some of the data shows that there is a rising burden of this problem. We're all going to be faced with it in cardiology. There's a very high mortality from this issue. Timing is of the essence here. The earlier things are recognized, the better the outcome will be. The use of temporary devices is going to become more and more commonplace, especially now with data from the Danger Shock study. But it's really a multidisciplinary problem. There's the interventional cardiology, heart failure cardiology, cardiac surgery, critical care medicine, nephrology. A lot of people get together to try to manage this patient. It's not a disease that's just, again, fixed immediately in the cath lab. And we still, I think, need more data from additional randomized studies to really try to reduce some of these adverse events and still hone down on what is the best population that would benefit from the use of these temporary devices. Thank you.
Thank you very much. This presentation is always great, but today is presentation. And I think because recently we have a lot of technology developed, and we have a lot of research to which device we can use to proper patient good timing, and then I think it's all covered everything, and then we need to know how and where to bring the device to the next step. Is there any
over those sensational, the audience recognize you're probably not going to get a better cardiogenic shock going anywhere. in the world. Can you go back to the danger? So danger shock, you all heard, it's probably the only positive cardiac shock trial we have, so it's getting a lot of attention. Can you go to the KM curve? Yeah. So you mentioned the issue of the 0.99 complex interval. A lot of those deaths happen, 150, 180 days. Do we know the causes of death? I mean, it might have been a couple of people got hit by a car, right? And then you got a positive trial.
Right.
Right. So do we know that? Does the trial tell you what the causes of death are and when?
They are listed. I don't know off the top of my head, but a lot of some of the deaths are late, like you're saying, as we see that standard of care curve go up, right? But many of them are in the beginning, and most of these are listed as multi-organ failure up front.
So can you go to the ECMO trial, the field? No, go back one. What's the duration of support on that?
Yeah, this is a really important point. So
Where's that?
yeah, so it's right there in the third from the bottom. So ECMO was only used for 2.7 days.
So that makes no sense.
Yeah.
These are people who got CPR, 70% of them. How many people are ready to go up to 2.7 days of support? Right, that makes something I don't understand this trial. Right? Can you explain that to us?
Yeah, there's differences. Maybe DR can also give us how ECMO is managed in Europe. At least just judging from this data, it seems like the device was deployed, and if
unless you tell me everybody went into Impella or everybody went into LVAS, no. One patient got an LVAS, everybody got transplanted, no. So why?
Yeah, it's too short.
So thanks, that was really a very nice overview. I think the problem with short trials is somebody who's not involved with management, people think, right, these are bad, you don't have to do it. You look at the numbers, just figure out right now, and you go to the detail, these patients were almost dead, and they got ECMO. So the main criticism for this trial is they got the very late waiting at the initial more than 6 hours. I think they were like the criteria to get at least hours, 6 hours or so. Luckily, value from 7 mean value, and then they got ECMO. My explanation of this outcome, I think it's not surprising that if you do this patient cohort are very bad condition that you won't get a good out. That's not surprising. The idea is for the question is how do you manage not to get to that level? And the timing is what I mentioned is to implant the ECMO early on. This is one problem why the outcome is like that. The other problem is what you just mentioned. Management of ECMO. There are a lot of right now in Germany at least, a lot of centers are implanting ECMO. With COVID, like everyone's doing ECMO. But the problem is, in my opinion, there are like 50, 60% of the centers, they know how to do it. They know how to manage the patient. Managing these patients, I will give a simple example. I worked in that phase. That's one part of the trial. Implanting a distal breathing catheter was not my use. They kind of waited some time until they just take a scheme and then implant benefit. So again, managing these patients is, I think, the key to get an optimal timing and management. That's the explanation of the outcome. It's not surprising.
Yeah, it's great to get the perspective because this study is from Denmark and Germany. And Germany say Denmark, that's why it's
Danger is Denmark and Germany. This is
oh, sorry. Yes, yes.
It's a multi-center trial. But danger, especially what Denmark is they recruit more patients, so they added Germany, so they call it danger trial.
Yeah, so thanks for correcting me. I'm quite interested because my next comment was in danger, but I would just, I don't want to very long, I would just dismiss the study. So based on the two days dwell time, because you cannot resuscitate and save the patient, no matter how sick they are. Somebody can save, and I think somebody can save the ECMO. If you pull the trigger at 48 hours, you basically have not given the patient a chance. That's why I would dismiss the danger study. Just to also make a big comment that I think the the take-home message from danger for me is a huge number of side effects, but with all the issues and mortality benefits. So the take-home for the communities, I think, yes, use the device in a setting, you better get your act together in managing it after, right? It's the same for ECMO. This is the theme, I think, for the field. I don't know if anybody in the audience has some comment. Francesco, yeah. And then,
Just a little closer. Why do you think mortality benefits should following dialogue?
Well, the question was, why did mortality optimal that they're very, I think we already answered this question. Probably not. I mean, one of the guys was involved in the trial. I used to work in the Asia trial outside. It's best simple with a friend of mine, and he's now working actually for Adam. He's now in medical direction with Adam. And you see also even in Germany, there are differences in outcomes. It's like anything else, like how we trial, momentum, you guys know that. I mean, it's all, I think mechanical support, like anything else we do, management is really key. And if you don't manage these patients, well, you're going to finish with an outcome. But again, that's what my explanation for that is. And there is one more thing which I really like to know from all of you guys. It's the number of impellers at the time of like including patients with these including criteria. Do you guys do more impellers based on the income?
I mean, I don't think there's been uptake. We were doing them before. I think this trial just shows now that the outcomes are more rigorously measured, some of the adverse events. But I mean, so it's just these findings just came out, a couple of months ago. It's hard to.
Do you guys expect more impellers?
yes.
Yeah.
Yes. And do you do impellers ahead of one of my questions or alone? We do the impeller first and then PCI or the other way around?
It depends on the individual interventionalist. So we like it to be done first to restore the hemodynamics before you restore the coronary perfusion. Because if you restore the coronary perfusion first, it can take however long to open up the vessel. Then you're continuing the end organ malperfusion and continuing starting further along that pathway of spiraling towards the cardiogenic shock, which may not be recoverable from inflammatory symptoms. I'm sorry, good job.
Quick question, often taught, it seems like all of these devices, 5.5, ECMO, do a good job restoring central hemodynamics. Obviously, the technology has to get better to decrease the adverse event profile, but the residual risk is still high, and is questioning the macro versus micro circulation. I wonder what is happening in the field to address that pharmacologically. It seems like that's something that people should really be thinking about.
Yeah, great question. I think not too much. A lot of the randomized studies are focused in this macro circulation process, but I completely agree with you. There's a whole black box here on what's going on at the end organ level in the small vessels, because that's where a lot of the damage is occurring. There's potential for a lot of targets. There was a study, way back in the day where there were these INOS inhibitors that were studied, and that was a negative study. And that, I think, some of the enthusiasm was gone because of that. But, we're starting to see more of these cases, and there's probably other pharmacologic targets. I think inflammation is one of them. It's a broad target, but whether that slowing that down would impact outcomes. So there's room to further study that.
You know what, we're not going to stop this discussion. I just want to move on a little bit from what was exceptional. This will be a YouTube hit, maybe the whole session. I do want to introduce the next speaker, because questions are, what are you doing at MonteHeart? And I think the lesson from these trials is that the benefit of the device outweighs the risk. That's very clear. You have to do it in the right therapy. That's why I asked Danny Sims to give us the next talk. Danny has been here a little bit longer than me, for just over 10 years, and really deserves credit for building our CPU, which is very different from I think, almost any
other CPU, and that is only managed by heart failure cardiologists, and you can see here in concert with our surgeons and our interventionalists, it's a closed unit in this regard, and we manage ECMO, LVAD, and everything. Everybody sick comes to our CCU that then runs, and we're doing an exceptional job doing that. That's why our outcomes are overall quite good. But when I asked Danny, he could also give a nice overview of talk, but I asked him to, what people need to learn is how to use these devices. So I asked Danny to just give us a bread and butter. How do you use these devices? What are the issues? What do you look for every day? So Danny, thanks for making this. Thanks.
Of course. Well, thank you, Uli, for that kind introduction. Everyone can hear me okay?
Yeah.
Yep, okay.
Project loud into it.
Projecting loud.
Yeah.
All right. So my disclosure slide, I'm a New York Mets fan who works here in the Bronx. This is a big disclosure, working in the land of the New York Yankees, the Bronx Bombers. So why temporary mechanical circulatory support? Shouldn't we just use pharmacology? Dobutamine, milrinone, norepinephrine, occasionally epinephrine. I mean, dobutamine is our first-line agent, and undifferentiated shock, the guidelines would say you should put them on norepinephrine. And in fact, we do make a lot of use out of drips, in spite of all the mechanical support we also do. And in fact, here at Montefiore, we use a special pharmacologic agent. Now, I'm not sure how well this projects, but this is Pinot Grigio. So this is one of our patients who was waiting for heart transplant, and he was getting a little upset that the wait time was going on for so long. So he hung a special pharmacologic agent on his IV bag. And he did well after transplant, and well before transplant too. So if you're just on one drip and a low dose of that one drip, you actually do pretty well. So the problem is when you go from a low dose to a moderate dose to high dose to multiple drips, your mortality goes up exponentially, okay? And this is data from surgical literature, but Babar Basir from the Henry Ford group and Bill O'Neill's group out in Detroit published this in cardiac patients. And these were from a Impella data set. So everybody in this study got an Impella. But the question was, when did they get the Impella? Did they get it before they were on drips or after they were on a lot of drips? So if they got the Impella early on, they 2/3 survived. But if they were even on one drip, now survival is down to less than 50%, and worse so as you get more drips. So a little bit of one pharmacologic agent, so mild shock or stage C by Sky that Omar started to mention, they could do okay. But these stage D, stage E patients, they need more. So what are our choices for temporary mechanical circulatory support? So we have our tried and true intra-aortic balloon pump. It expands during diastole. It's deflated during systole. Our Impella CP, our Impella 5.5. The tandem heart device, in which you take blood out of the left atrium and it goes through a rotor and then is put back in the femoral artery. Not used that much anymore because of the complexity of doing a transeptal puncture. So I'm not really going to spend time talking about that. And then, of course, VA ECMO shown here with peripheral cannulation. So let's talk about the intra-aortic balloon pump. So during systole, the balloon pump is deflated. And as it deflates, it creates a suction mechanism, which makes it easier for that weak myopathic heart to get blood to go out of the aortic valve. It lowers the afterload, and so blood then goes more distally. And then at the onset of diastole, at your dicrotic notch, you get inflation of the balloon pump. And now blood is sent retrograde and can help perfuse the coronaries, and then also is pushed further along in diastole to perfuse the end organs more distally. The Impella, the balloon pump we usually put in via the femoral artery, but there are other ways to get vascular access. I'll go over in a second. It doesn't supply that much mechanical support, only between 0.5 and 1 liter per minute of extra flow. It does offer some unloading, but just a little bit. It's pretty easy to put in. It can be put in at the bedside in the cath lab. It can be put in the OR. And it's pretty easy to manage, particularly with the modern optical balloon pumps.
There's minimal risk for limb ischemia with the smaller generation balloon pumps, almost no hemolysis, very little bleeding. Now, who do you not want to put a balloon pump in? Someone with severe aortic insufficiency, someone with severe peripheral arterial disease, as well as someone with a severely diseased aorta. So timing-wise, as I mentioned, the balloon pump inflates during diastole, so you get what we call diastolic augmentation. So our diastolic pressure is now much higher, and then it deflates at the onset of systole. And as a result, it's easier to get that blood to go out of the LV. So our assisted systolic pressure is lower. And here you see how the waveforms look on a contemporary panel. Now, I said before on that slide, it's relatively easy to operate a balloon pump. That didn't used to be the case. You know, back when I was in training, we used to always have to go and adjust the timing of the balloon pump. The inflation, does it need to be earlier? Does it need to be later? The deflation, does it need to be earlier? Does it need to be later? I don't remember the last time I did this. The optical balloon pumps that we use now, the modern balloon pumps, the computer is really good at doing this, such that when I start to tinker with it, actually make the hemodynamics worse. So we generally don't need to do this anymore as long as you have a stable rhythm. So balloon pumps have been out for a while. So I want to just spend one slide talking about its history. So it goes back, the initial publication, 1968 in JAMA by Adrian Kantrowitz. And the balloon pump looks pretty similar to our current balloon pumps. You know, here's the sausage-looking balloon where the helium goes in. And as you look over here, here is where you turn the balloon pump on. And this is the carotid artery waveform. And you see the diastolic augmentation as well as the lower systolic pressure. So it was doing the same thing back then that we're doing now in the year 2024. So Adrian Kantrowitz, who invented this, saved a lot of lives by having the balloon pump invention. Now, a couple other fun facts about Adrian Kantrowitz. He actually trained here at Montefiore as a surgeon. He was on faculty here at Montefiore, and then he went off to Maimonides in Brooklyn. The other fun fact about him is he actually did the world's first, the United States' first heart transplantation. So that was done in 1967, just a few days after Christian Barnard in South Africa did the world's first heart transplant. So Dr. Kantrowitz did quite a lot for the field of cardiovascular medicine. Balloon pump positioning is important. So when we put it in via the femoral artery, as well as when we put it in the axillary artery, you want the balloon pump to sit distal to the subclavian artery, so you're not obstructing that, and above the renal arteries. So nowadays, when we put it in from the groin, we use these stat locks to put it in place. Previously, we would suture it, but these things would move. So when you have a stat lock, it's very easy to unlock the balloon pump and put it to standby and move it up or retract it backwards if need be, rather than having to cut sutures and resuture, which was always an ordeal, and made it such that people were less likely to reposition it when it needs to be positioned. So over here is a patient, huge heart, ICD in place, swan from the leg, who has an intra-aortic balloon pump. And here's our balloon pump marker over there, and I'll highlight in red to try to make it a little bit easier for you to see. And it's in a good landing zone between the top of the aortic knob and the carina. And we look at the chest X-ray every single day on our balloon patients in the CCU to make sure that they don't migrate, because they can get yanked. And here's a patient where it got yanked too far distally as a patient was being placed onto a stretcher and had to be replaced. And when the balloon pump is malpositioned, you're not going to get even that 0.5 to 1 liter per minute of extra flow. Here's another patient. This balloon pump is in via an axillary approach. And so what usually is the distal marker is actually now our proximal marker, because the balloon pump is going down towards the descending aorta. And here again, it's in good position that we can see here. But now it's pulled back some. So this is a problem with our axillary balloon pumps when our patients are ambulatory, where it's hard to keep it in good position. So this patient, needed to have it pushed further in such that we're not going to get a problem with vascular complication and insufficient support. So this is something we noticed here at Montefiore. So we have a patient who had an axillary balloon pump and was ambulating and waiting for transplant. And here's their marker over here. Let's see if I can just move this out of the way slightly. Here's how it looks with the balloon pump coming in and sitting in the descending aorta, okay? But then the patient, a few days later, decompensated and needed to be put emergently on ECMO, VA ECMO peripherally. So they had a femoral artery arterial cannulation. So now blood, there's my mouse here, there's my mouse. The blood is streaming up towards that balloon pump. And actually, we didn't recognize it at the time because we didn't have much experience with axillary balloon pumps and VA ECMO. The balloon pump was pushing, it was alarming, not providing sufficient support. We didn't quite understand. We thought, okay, it's just related to the what do you call it, the VA ECMO. We weren't following the chest x-rays quite so closely. This is back before 2020 when we had this published. And so it actually migrated, and you can see by the markers here, into the aortic arch. Now, a day or two later, a heart transplant's available. Yay. So patient goes down to the OR, they're getting off ECMO, they're getting the balloon pump taken out, and we had a phone call from Dr. Goldstein who says, hey, your balloon pump, it's in the LV. It's not supposed to be in the LV. So it actually, with that flow, pushing it all the way back and into the LV. And it was really quite remarkable to see the transesophageal echo. I wish I had it here to show you today. So management and following the balloon pump and the positioning is very, very important. Okay, so let's talk about the Impella. So we've heard quite a lot about Impellas already, but here it is in a little bit more detail, the CP device here. Here's your inflow area, and then the outflow area for the blood comes out, and your motor. There's also this optical sensor over here, which helps the Smart Assist work. The Impella is put in, it's a transaortic, so it's put in retrograde across the aortic valve into the LV. And depending on the iteration of the Impella, so the CP can provide about 4.3 liters per minute of blood flow at maximum P9 setting, and the Impella 5.5 obviously can provide 5.5 liters per minute of flow at maximum. You get much more unloading than you do with the balloon pump, but it's a little bit harder to put in. In fact, you have to organize an OR if it's an Impella 5.5. You have to be down in the cath lab for the Impella CP because you need fluoroscopy. You need to be able to do retrograde access, which our interventionalists are capable of doing. They do it all the time. It is more complex to manage, and you'll see what the controller looks like in a second, particularly compared to the automation that we have nowadays with the balloon pump. And obviously, there's a risk of limb ischemia with these larger cannula. Hemolysis is significant, hemorrhage risk. Who do you not want to put an Impella in? You don't want to put an Impella cannula into the LV when there's an LV thrombus in there. You obviously can't put it across a mechanical aortic prosthesis. When there's severe aortic valve disease, you can't put an Impella in. And then you don't want to put it in someone that you can't anticoagulate them. So the Impella positioning, a little bit harder. Chest x-ray, not so useful for the Impella. So we rely more on fluoroscopy and echocardiography, as well as on the Smart Assist. So let's take a look at a couple of echo-ish pictures here. So for the Impella CP, the inlet, not the pigtail, but the inlet, backwards, should be about 3.5 centimeters below the aortic valve, and the outlet should be above the aortic valve so that everything that you take in gets ejected out into the aorta. Now, to figure out exactly where it is, because there are, all these imaging artifacts, color flow can be helpful. And so this is what good position would look like, where the color flow is essentially all into the aorta and not a lot of it over here still into the LV. You're just taking blood from towards the LV apex and ejecting it into the LV by the base and the LV outflow tract. That doesn't really help with your cardiac output. But this is a problem if the Impella is in too far. So this is a patient who came in shock. It was acute MI, cardiogenic shock, and you can see that they already have a swan in, and now they're doing a diagnostic angiogram. You can see the occluded LAD, but before they went and did the intervention, they went to put a wire into the LV, and the interventionalist is putting the Impella into the LV, and you can see that the pigtail is going to come out in a second here. Now we're crossing the aortic valve, and they're going further, and there's our pigtail. Positioning, echo is very helpful for this. So here's an Impella 5.5, which we want about 5 centimeters. This one measured about 5.5 centimeters below the aortic valve. And my slides are advancing without me clicking. So this is pretty good position. Here we put on color flow, and you can see that it's all, the flow is distal to the aortic valve. So this is good positioning over here. This is not good positioning or malpositioning. Here the Impella is in too far, and the pigtail is actually getting caught up in the papillary and the subvalvular apparatus. So this is no good. And so, apologize. So if you look at the schematic here, this is what's happening in this patient, where it's just getting caught up over here and causing problems with the mitral valve. So here's an Impella that's not in far enough. You can see there's barely anything coming out in this parasternal long axis view. That's usually the best view. Sometimes we'll get other views wherever we happen to see it best. Here's an apical 4 chamber, where again, it's just not extending out past the apical 5 chamber, excuse me, not extending past the aortic valve very much into the LV. The color flow is all in the aorta because the Impella isn't in very far. So it's difficult. As you probably got the impression there, not all the echo pictures are wonderful. Not everyone's got great echo windows. So we also rely on the Smart Assist. So if you look at the waveforms, it's very important because you can see your LV tracing and you can see your aortic tracing. And this is what you want to see for the patient, so that you know that the inflow is in the LV and the outflow is in the aorta. You also see a nice differential in your motor current. What we're also learning is to pay attention to the purge pressure, because this can let you know a little bit about thrombus formation, hemolysis. But this is a patient that you're not in far enough, so it actually started coming out. And you see here that your LV tracing now looks like an aortic tracing. So this is not in far enough. You don't have to get an echo to know that that's what the problem is and why the pump is alarming. And similarly, here's one where the Impella is in too far, and now your aortic tracing looks like an LV tracing. So it's in too far. Again, you don't have to wait to get the echo. You know what the problem is and can start to fix it. So Omar mentioned hemolysis. Hemolysis is a big problem with these pumps. And I'm about to show you something pretty gruesome that I don't really like to show to cardiovascular specialists, but I think it's very important that you see this. And this is a picture of urine. And it's a picture of hemolytic urine that's all bloody and disgusting and terrible, and we don't want to see this. And as a heart failure specialist, I spend a lot of my day actually looking at Foley bags or looking at the handheld urinal to get an idea of how the heart is doing and how the perfusion's doing. This is what you don't want to see for your patients. This isn't traumatic insertion of the Foley. This is the patient is hemolyzing for some reason. So in this case, the Impella was in too far. It was causing contact with the subvalvular apparatus. So we had to reposition it in the cath lab with fluoro, with echo. And you can see it's the same Foley bag. Here's the dark urine that's still in there, but now we're starting to get lighter urine that's coming out. And when you look at what's closer up on the Foley cannula here, it's all nice and clear. So you can reposition these to correct some of the complications and problems and prevent it from getting a pigment-induced nephropathy. So I mentioned we use other vascular access points. So for balloon pumps, we'll put it axillary. And both of these patients gave their permission for me to videotape them and show pictures of them. So this is a patient on the left over here in the CCU, ambulating with a balloon pump in, maintaining his physical performance such that he'd be a better candidate, a good candidate to go through transplantation. Over here, which is another patient with an Impella 5.5. And so he's ambulating as well. again, to maintain his performance status and be a better candidate for transplantation. Okay, VA ECMO. Here put in peripherally, venous blood coming out of the inferior vena cava by the RA, going through a rotary pump and then the oxygenator, turning it bright red, and then being put back into the femoral artery. Provides biventricular support as compared to the two other pumps I just showed you. Can get over 5 liters per minute of flow. And there's 0 LV unloading with the ECMO, as Omar mentioned. It's more complex than a balloon pump to put in, and in some ways easier, some ways harder than Impella to put in. But it can be put in at the bedside or put in the OR or in the cath lab. It's harder to manage. There's a lot more that goes into it. And because these cannula are so big, you have significant risk of ischemic limbs, hemolysis, and hemorrhage. Who don't you want to use VA ECMO with? Anyone with severe aortic insufficiency, severe peripheral arterial disease, contraindications to anticoagulation. Obviously, there are other contraindications in patients we wouldn't put in, but those are the placement issues. I mentioned there's 0 LV unloading. So VA ECMO is the only temporary mechanical circulatory support device that increases afterload. And I could spend a whole hour showing you pressure volume loops and what cardiogenic shock does and what all the different pumps do to the pressure volume loop. But I did just want to do, but I'm not going to do that. I just wanted to show this one. And so here's a patient in cardiogenic shock, and the width of the pressure volume loop is the stroke volume. And this patient got ECMO, and as you turn up ECMO and go from 1.5 to 3 to 4.5 liters, your stroke volume actually decreases. The width of the pressure volume loop decreases. And your E little a, your end systolic elastance slope goes up, and that's your afterload. So that the pressure that the LV is pumping against is much higher. And as a result, your LVEDP is much higher. So you can get pulmonary edema, you get increased afterload, and the inability to rest the heart and decrease wall stress. So what can we do to fix afterload? Well, we can start with dobutamine to get the LV contracting. But if that doesn't work, there are other options. So if it's in the OR, you can put a surgical cannula in. You can put a cannula in the pulmonary artery that removes blood. You can put a left atrial cannula in over here. You can actually do a balloon atrial septostomy. And as a result of that, blood from the LA can then go into the RA. We can put an Impella in retrograde across the aortic valve and suck blood out of the LV. Or a balloon pump can make it easier for that weak and failing left ventricle to eject blood forward. All right, let's shift gears here and talk about hemodynamics. So here's your pulmonary artery catheter, your friend. And I do mean that. The pulmonary artery catheter is your friend. A lot of my colleagues in the MICU think the pulmonary artery catheter is the enemy, and that's simply just not the case. So let's look at a few waveforms here so we're all on the same page. So this is a right atrial pressure tracing. Normal is about 0 to 8. And then we get a systolic step up as we go into the RV. Normal RV pressure is about 15 to 25 over 0 to 8. Why over 0 to 8? Because in diastole, the tricuspid valve is open. And as a result of that, there's equilibration of that right atrial pressure and the RV pressure. In this case, the pressures are a little bit high. Here, it's about 40 over 3. And then as we float further along, we go into the pulmonary artery, and we get a normal PA pressure, which is 15 to 25 over 8 to 12. So you get your diastolic step up. Why is the systolic pressure 15 to 25? Because during systole, the pulmonary valve is open. So now there's equilibration of pressures between your RV and your pulmonary artery. And in this patient here, our pressure is about 37 over 15. And then as you continue floating along, you'll achieve your pulmonary capillary wedge pressure or pulmonary artery occlusion pressure. Normal is about 8 to 12. Now, I really like this particular slide or this particular tracing because you can actually see your A wave and your V wave. Your A wave is atrial contraction, your V wave is atrial filling. And so over here, time to the QRS is your atrial contraction, and time to just after the T wave is your V wave for ventricular filling. So why do we care so much about the wedge? The wedge, what's the wedge? Did we lower the wedge? What's the wedge in this particular patient? Because the wedge pressure in the absence of mitral valve disease, so not a mitral stenosis patient, the pulmonary capillary wedge pressure approximates the left atrial pressure, which approximates the left ventricular end diastolic pressure. And the left ventricular end diastolic pressure is your gold standard for preload. So in this patient over here, they put in a PA catheter from the neck or the subclavian, and it floats into the brachiocephalic vein, into the superior vena cava, into the right atrium, across the tricuspid valve, into the RV, out the RV outflow tract and pulmonary valve, into the main pulmonary artery, and then wedges in the LPA, and we get a static column of blood, which is as if we're transducing the pressure from the pulmonary vein, and there's no valves over here, which is as if we're transducing the pressure in the left atrium. And when your mitral valve is open in diastole, that's you getting a measurement of the left ventricular end diastolic pressure, an approximation of it. So pulmonary capillary wedge pressure is affected by respiratory mechanics. So we always want to measure the pulmonary capillary wedge pressure at end expiration. So we're all speaking the same language. When alveolar pressure and pleural pressure are both 0. So everyone in this room here, we are spontaneously breathing. We are negative pressure breathers. We take a breath in, our pleural alveolar pressure goes down. We take a breath out, our pressure goes up back to 0. So this is where you want to measure the wedge pressure. Now compare this to someone who's getting mechanical ventilation, which is actually positive pressure ventilation. There it's reversed. You take a breath in, or really we blow the breath in with the ventilator, and the pressure goes up. The breath comes out back to the 0 baseline, and that again is where you want to take your wedge pressure so that you have the correct measurement. So the computer just averages this. It doesn't know, it's not looking at a respirometer, it's not looking at the patient. So it's going to just average the high and low values. So the computer is going to see this spontaneously breathing person and get a high pressure of 17 and a low of 5 for 22, and that's equals an average of 11. But really end expiration is up here, the higher number, so about 17, 15, so the average of 16. So now we're talking about someone who's a little bit volume overloaded versus someone who's got a normal wedge pressure. Maybe there's a clinical difference there, maybe not. In this mechanical ventilated patient, we blow the breath in and then the breath comes out. So the computer is going to take that 17 and 9, get an average of 13, while the actual value is going to be the average of 11 and 9 over here at expiration for 10. So there's no clinical difference between a wedge of 13 and 10. It's just really not clinically different. But what about this patient over here, where we have end expiration? This is a patient breathing ambient air. So like you and I just lying there. It's hard to figure out what their volume status was. So we did a PA catheter. And so their end expiration pressure is about 44, while their end inspiration pressure is about 10. So now we're talking about 44 versus 10, or 44 versus the average 27, where there's a big difference between those readings. So it's very important to measure the pressure at the right time and report that. There's other very important hemodynamic parameters, which I don't have time to talk about in depth today. Cardiac output and cardiac index, obviously, the cardiac power output, which is just the mean arterial pressure times the cardiac output divided by a constant of 451 to convert it to the unit of watts. The systemic and pulmonary vascular resistance are very important. The transpulmonary gradient, which is the mean PA pressure minus the wedge pressure. When it's greater than 15, that's concerning. And more recently, we started looking at the pulmonary artery pulsatility index, or PAPI. The PAPI is the systolic pulmonary artery pressure minus the diastolic pulmonary artery pressure divided by the right atrial pressure. So the lower the value of the PAPI, the worse the RV is doing. So if the PAPI is 2.5, 3, the RV is doing quite well. And as you go lower, and there's different cut points for RV infarcts or patients for risk of RV failure after LVAD, the lower the value, though, the worse the RV is doing. And my colleagues up in Boston like to call it the big PAPI. For my colleagues here in the Bronx, I will move on to the next slide. Complications. So like anything we do, there's a risk of complications, but a PA catheter is pretty safe overall. Anytime you nick the skin, there's bleeding, infection. Anytime you go in from the neck or the subclavian, there's a risk for pneumothorax. You have risks of heart block, ventricular tachycardia. When you tickle the myocardium, you could knot the catheter, you could cause valve trauma. If you blow up the balloon too distally and not paying attention, you can perforate the pulmonary artery. If you leave the balloon too distal, you can cause a pulmonary infarction. But by far and away, the most common complication of pulmonary artery catheterization is misinterpretation of the data, which is why we're spending the time talking about it today. Omar already talked about patients in shock and the differences among them. So Omar mentioned the ESCAPE trial. I want to spend just a half a second talking about it. So it was a randomized study looking at patients with acute decompensated heart failure, treatment guided by clinical assessment only or clinical assessment plus a PA catheter. So for those acutely decompensated heart failure patients who are cared for by heart failure specialists, the primary endpoint, days alive out of the hospital, 180 days, absolutely zero difference. The curves are completely superimposable. So there's no improvement when you added on the pulmonary artery catheter. In fact, there were more adverse events, and this is why my colleagues in the MICU say pulmonary artery catheters are bad and that they kill people. There were more line infections, a few, and there were more ICD shocks. However, the mortality wasn't different. It's not killing people. Oh yeah, these were all just acutely decompensated heart failure patients. These were not cardiogenic shock patients. Omar showed you the data from the cardiogenic shock working group by my colleague Rashad Garan. And you see here that the stage D, the stage E, the mortality was lower for the patients who got the PA catheter. The C3TN, the Critical Care Cardiology Trial Network, which is another registry looking at patients admitted to academic tertiary care CCUs across the country and Canada, they looked at this too, and they found that patients who had a pulmonary artery catheter had lower mortality when you adjusted, both absolute and then adjusted when they looked at who got the pulmonary artery catheter. So putting it all together to take care of these sick cardiogenic shock patients who have all this going on in the room, well, you need the PA catheter over here and the monitor up there to take care of the patient. You need your drips, your vasoactive medications to take care of the patient. You need your Impella and your Impella console or whatever mechanical circulatory support device. You need your VA ECMO, but you also need these other things. You need CRT, you need inhaled nitric, you need the ventilator. And most importantly, you need people who know how to do this. You need a multidisciplinary team. You need experts, not just put in the device, set it and forget it. You need people who can adjust things, people who can look at all the end organs, people who can take care of the patient. So let's leave with just a couple of questions. So there's going to be an easy and a hard question. I won't tell you which is which yet. So what would you report as the pulmonary capillary wedge pressure for this patient? I tried to help you out by putting in the respirometer and labeling it where inspiration is and where expiration is. Is it 43? Is it 3? Is it about 23? Or I don't know. All right, so most people put average of 23. So again, what we want to do, and then the second highest choice was 43. So what you want to do is take it at end expiration. So end expiration is over here, which is about 43. So it's actually the higher value. So there is utility in knowing what the mean wedge pressure is or throughout the respiratory cycle. but what you want to report for standardization is the 43. So I think that this was actually the easy question. So now I'm going to give you the much harder question. Who is going to win the debate? Dr. Castagna, Dr. Vukovic? We're not sure. Bring on the debate.
Thanks, Dan. That was, let's vote. Oh, we're voting first. Okay, great.
Okay.
Anybody who didn't pick the 43 can participate. That's it, right? That's great. I want those slides. Fuck Academy. Okay, it's on. It's on. So Danny, that was really great. I think both Omar's and Danny's lecture, I'm just thinking they have to be mandatory requirement for our residents and fellows running in our CCU, that they have read that and answered a couple of questions. I mean that. Great. So Francesco Castagna is next. Francesco was a fellow here at Montefiore and then spent the past year at the Brigham, Harvard, and has seen the light and will return in 2 weeks as faculty with the heart failure group. He's also currently applying for an NIH grant that actually relates to mechanical support. So Francesco, take down Dr. Vukovic.
Thank you so much, Jordi, for the great introduction. Let me start by saying that it's a great pleasure for me to be here in a place that I like to consider home. But let me also say that I believe I got assigned the toughest task today. And I'm not talking about defending a balloon pump, but rather arguing with Sasha. And I'm not here today to sell you that balloon pump is the solution for every single case of cardiogenic shock, because this good for everything concept in medicine simply don't exist. I'm here to tell you why I think, and I hope you will share my same view, why we should at least always consider balloon pump as a first line for every single case of cardiogenic shock. I don't have any disclosure. Like every good clinical debate, let's give a context, let's give a face and a story to this debate. And this is the story of a 60-year-old lady with common post-medical history, diabetes, high blood pressure, high cholesterol, that unfortunately a few years ago got diagnosed with breast cancer. But fortunately for her, she was cured with a combo of a surgical and a medical treatment. And life was good until last year, more or less around the same time right now, she presented to her PCP, complaining of shortness of breath, dyspnea on exertion, edema, weight gain. The PCP immediately referred her to a cardiologist, but unfortunately, she wasn't able to reach that appointment because a few days later, she showed up to our emergency department with some short episode of slurred speech that resolved spontaneously. But anyhow, she got admitted for further investigation, and that was the time when we found out that she had this new reduction in the rejection fraction from a previous normally reported EF. Now it's 35, global hypokinesias, left heart cuff with no significant lesion. So she was started on GDMT and sent home with a close follow-up. In the following week, we noticed a slight worsening of creatinine, not totally unexpected while we were playing with GDMT. But unfortunately, a few weeks later, as we too often see in these cases, she presented again to the emergency department with an episode of decompensated heart failure, received diuretics, GDMT optimized, and discharged home. A few weeks later, we decided to place a CRTD. Her ejection fraction didn't improve after 3 months of good medical therapy. Her QRS was long enough to justify it. We hope that could have helped. Unfortunately, she presented again a few weeks later, another episode of decompensated heart failure. At that time, we start talking about advanced therapy, bad, possible transplant. She got overwhelmed by the conversation and she decided to go home. And again, for the third time in less than 1 year, she presented with a heart failure decompensation. but this time was much worse. She was hypotensive, she was cold and wet. The device showed multiple runs of non-sustained VT and episodes of VT that were successfully terminated with ATP. She was admitted to our unit, the CCU, as one GANS was placed, and the number confirmed the suspected picture of cardiogenic shock with a left side component. Blood test more or less remarkable for lactate elevation and low sodium and potassium elevation, something we've seen basically in cardiogenic shock patients. So this is the moment where hypothetically I will ask you, what will you do for this patient? Somebody may say, let's start with an inotrope. Well, the patient is hypotensive, there are some electrical instability, so that's probably not the best choice right now. This is the moment where we actually have to think about mechanical support. And what will you do? Will you put a balloon pump or will you put an Impella CP? Because I haven't told you it's 3 a.m. and forget about activating the OR. So the options are balloon pump or Impella CP. Data based on experience. But most importantly, the question is, what will Sasha do in this case? I trust Sasha. Sasha is a great physician, he's a smart doctor, and he always knows what is best for his patient. I really trust his clinical management. And to answer to this question, what Sasha will do, let's see how we treat patients here in cardiogenic shock at Monte when they need a device. If you look at the data from 2022, when I was here, we had 10 patients who receive an Impella and 81 who receive a balloon pump. Now the question is, who do you think plays most of the balloon pump here? Sasha Vurgalich. I told you, Sasha is a great doctor. He knows what is the best for his own patient. And why does he do that? Because he knows that balloon pump works. You must have heard this mantra, oh, balloon pump can give you, at best, alpha liter of extra support. Let me tell you this, that's not true. If we look at the data from other centers and from this center, we see that in the majority of patients, balloon pump is able to provide a much higher support. So this concept that we can always, in the best case scenario, provide this alpha liter, it's simply not correct. And what is the secret? And this is something we learn over time, but every time we have a patient in cardiogenic shock, we should always ask ourselves, is this patient going to fly on balloon pump? In other words, which are the predictor that will tell us if balloon pump is going to work or not? And it is critical to think about this before we commit to any specific device. And what we have learned over time is none of these patients do well on balloon pump. I mean, the cardiac output increased quite a bit. Patients that start with a low cardiac output have a good response. Diabetic patient with a good RV function, patient that are on pressure or have high SVR responded well. Similar with patient with mitral regurgitation, and similar with patient with non-ischemic etiology of the disease. So we know that if we are able to identify this patient, we're able to provide them a great hemodynamic support with balloon pump. And you could say, but why do we have to go for this? Why we have to start thinking about he's going to do well, he's not going to do well? Why can we can just shave up an Impella in and call it a day? Well, these devices are no joke, and the price you pay when you increase the cardiac output is also the fact that you increase the risk of complication, and we know that Impella has a much worse profile. If you look at the major bleeding, Impella is much worse. If you look at the bleeding from access site, ask any of the fellow here which is the device that bleed the most. And usually it happens at 3 a.m. when there is nobody around. Impella. Hemolysis, Impella is worse. Thrombocytopenia, Impella. CVA, more or less the same, I must admit. Limb ischemia, sepsis, device migration, device malfunction, Impella, 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 Impella. So going bigger is not always the best because we know that Impella has much more complication. And okay, I show you that balloon pump can provide good cardiac output if we are smart in the way we use. I show you that balloon pump has less side effect. But you may ask, what's matter? If everybody on balloon pump die and everybody on Impella survive, why do we even have to talk about that? Good question. But when you look at the data, there is no difference in survival between the two devices. So time is a little short here, and let me give you my final thought, my take-home message for this debate. We should always look at the patient and ask ourselves, can balloon pump work in this patient? Simply because we have a bigger, fancier, more powerful device doesn't mean that we have to use it. Because if we go big, complications also go big. And this is the critical point. If you're able to provide good support with a device that has much less complication and also cost less, why should we go out and look for trouble with something much more complex and with more complication? And this is the critical point, and this is something I would like you to think about every time you have a cardiogenic shock patient. I would like you to take a break and think, is this patient going to fly or not on balloon pump? And this is why balloon pump should always be our first line of forward. Now, to look back at our patient, these are the characteristics that predict the success of balloon pump. Let's see our patient, how she matched this. BMI, low cardiac index, diabetes, good RV function, high SVR. We don't have a mitral regurgitation, but we have a non-ischemic etiology. So let me ask you again, would you consider balloon pump for this patient? Thank you so much for your time.
Yeah. So Francesco, that was outstanding. You're the new kid on the block, so you have to win this debate. Dr. Vukilic, on the other hand, really does not need to win anymore. Sasha joined us, 7 years ago? 7 years ago, initially as a fellow, maybe that was 8 years ago, and everybody knows him here. I don't have to talk much about him. He's loved in this institution. And Sasha has made some important publications during his time here, actually, and has become our go-to person in the cath lab, managing hemodynamics, evaluating lung transplant patients. And I'm very proud that Sasha is becoming section chief for heart failure, transplant, and VAD. He has to build the VAD program and the transplant program, but he will, at Tulane University. So it's a big accomplishment for him, and a big accomplishment also for us and for MonteHeart that we're staffing other centers. So you don't need to win, but I know you're going to try.
Hi, everybody. This is really difficult for me as a presentation to do it. I was thinking about it, and I'm trying to tackle 2 jobs here and in New Orleans, and then I was traveling, and it's Francesco. We're very close. Francesco was my fellow, you know. I'm born in Yugoslavia, that's neighboring country to Italy. I went many times in Italy, especially around the Milano in North Italy, or how Francesco just called it, Italy. Somehow he has some strange geography that South Italy is different continent, but you know, the things are special there. So, you know, we both are into Formula One. I love Formula One. I watched it. I went to multiple ones. And Francesco went to medical school in Monza, which is famous in Italy by being built next to the racetrack. Very famous racetrack, anyway. And we were very connected. He was my CCU fellow and everything. But last couple of years, or last year after he went to Harvard, the things become a little bit strange. I was a little bit feeling some strange vibe. And, you know, it's like that really partially influenced this presentation. He went there, and then he started spreading rumor that I told him he should go to Harvard to compensate for that racetrack thing anyway, you know, medical school next to racetrack. And then this year we went to ASHLT in Prague, and I said, oh, Francesco, I'm going to Milano. I'm going to take a close detour, go to Switzerland, but I'm passing your town next to the Lago di Como. And he says, oh, when are you coming? And I'm like, April 4, like, you know, what time? Oh, okay. I rented the car, and what happened? I was passing his hometown, and I was stopped by police. It's the craziest thing, anyway. And I got ticket. I never really drive fast. I'm famous about not driving fast, but they claim I drive fast. And then there's a name on that person, Alessandro Castagna. It's really weird. But, I thought it's good. We kind of hugged in Prague and everything was doing great. And I was, okay, I'm just going to do the great presentation. I love Francesco. I love balloon pumps. I will just do what Italians usually and traditionally do in the wars. I would just surrender and let him win. And so it's like, But I got a little bit disturbed. I'm leaving. And yesterday I'm rounding CSU. I'm coming back to my office. And there's a different name on my door. And it says Francesco Castagna, MS. And I'm like, I'm Sasha Vukelic, PhD, and MD, PhD. And then I said, okay, I'll be bigger man. I'm not going to take it. And I know it's not Francesco. It must be Dr. Patel. I have Wanda from Human Resources on speed dial. She also has him. So it's probably that anyway. So then I decided you can do it ad hominem, like some presenters here do. Take like hidden pictures when people are vulnerable, when they're floaty, and use that as an argument, or you can really tackle the argument. So that's what I did anyway. So I decided to be a bigger man anyway. So Francesco really did this case when we were together in CCU. He was a fellow and I was attending, so we shared the case. So I won't go through the whole, I don't have conflict of interest. I won't go to whole presentation because I learned from my mentor, Dr. Yordi, that presentation should be ejection fraction is 30%, LVDD is 6 centimeters, blah, 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 blah. So I cut it at perfect part when there is this 60-year-old lady who most likely has anthracycline-induced non-ischemic cardiomyopathy, which is famous by being biventricular failure, which we very often cannot do LVAD. And this lady now had repeated readmissions. She's not doing well. Francesco got her in CSU. She's in shock. He calls me and tells me, listen, she's cold and wet. There's edema there. And there's most likely elevated filling pressures on right side, I think in my head. And she also she's hypoxic, which probably tells you there's elevated filling pressures on the left side. She's developing some pulmonary edema on chest x-ray. So based on the data from Dr. Sims, her wedge pressure is probably 25, 30 or something. And, she's hypotensive, not a lot of afterload, not really clamped. So I said, okay, now there are runs of NSVT, ATP, so she's really dangerous. You know what happened when you go to VFib? How much is your heart pumping? Anybody? It's not pumping. So balloon pump depends on the heart pumping, which is not the case in that situation. So Francesco put this one and he called me with numbers and I'm like, okay, this kind of doesn't fit the picture. You can see that RA is 9. The wedge is only 19, which is really not cardiogenic shock. Cardiac index is low. And I'm like, okay, I went back to CSU. I re-leveled the patient, look at the breathing, and got the numbers. That's experience anyway, which are more fitting the picture of cold and wet person. You can see the RA is 19. The wedge is 30, which is more likely that somebody will have pulmonary edema and hypoxia. At 90, it probably won't happen. And you can see the puppy score is really low because she has anthracycline cardiomyopathy, which is famous by the RV failure. The puppy is only 0.5. So that kind of pushes our story in a little bit different thing. So there is low MAP and there is high wedge and high RA pressure. And you can see the numbers. She's going into the hypoperfusion with creatinine elevated. There's AST and ALT elevated with shocky liver and congestion a little bit. And we agreed to follow up Francesco. That's how you learn from errors. That's what you need to be brave as attending to allow your fellows to make an errors, which they can correct and they learn. So we put the balloon pump. This is what balloon pump does anyway. Dr. Sims went very well about that. So it's a minimal effect, Cardiac output increase is 0.5 to 1. This lady has BSA of 2.6. So that increase in cardiac index will be 0.2. So she went from 1.6 to 1.8. So it's very suited for people who have huge afterload because Francesco didn't do the good measurement. His calculation of SVR was 1900. And, it looks like she's clamped down. But when you change it, it's really like 1400. So she's not really afterloaded. And, you know, it's very good for better perfusion of the coronaries, which she doesn't have problem with, coronary artery disease. So what happened? We put the balloon pump. Now the pressures, you can see, it's a little bit lower diastolic, augmented, okay, she's a little bit, but she still doesn't have good urine output, despite that she is on Lasix 200 and diuretic 250. And this is what we got with the numbers. You can see there's some mild drop in wedge, mild increase in cardiac index, but Ara is even worse because her right side is worse anyway. And she has biventricular failure. And now she has more runs of NSVT, and then she goes to VTAC, and the balloon pump, when she went to VFib, is really not doing anything because it depends on the cardiac pulsatility. So she really loses the pulsatility. She needed ROSC, and it was really, really difficult. And this is the problem where we come. We use it from 1967 balloon pump, and it all comes to this slide. We can slice it and dice it. There are some people who are responders, definitely, but overall, after this slide, you can see this is 600 patients for this trial, and there was really no benefit in Europe that led that it was downgraded from class 1 to class 3, which is do not use. And in the US, that's why we use it still, is class 2B, which is that yellow kind of sign. You should be very careful and carefully select. But this is the reason why the injured trial came in Europe, because they completely abandoned balloon pump, which I think it's wrong. There are specific patients you can do. And you can see there was no difference on 30 days, there was no difference on 6 months, and there was no difference in 6 years. So really nothing was doing. And you can see what's happening with our patient because I let Francesco to make that error. You can see that creatinine is rising, AST and LT are rising. She's going into shock liver. And should I let him longer to do it? Probably not, because she's really not the responders. Like she's putting there, she has heart failure with lowish but not terrible cardiac index. Her RV function is terrible, PAP 0.5, which is expected in anthracycline cardiomyopathy. SVR is so elevated, and the wedges was really high anyway. So she was really not the perfect candidate, probably from balloon pump. So now we come, so I should just swipe it anyway. So that's what you guys will do in this situation. You saw it. Now the option is, what should we do? Should we convert it or not? And Clyde, nothing? That's not me. That's okay. I'll just go back so we can vote anyway. So what should we do? Convert to Impella 5.5, continue aortic balloon pump. Who is for the continuing balloon pump? Is there anybody? Oh, nobody. Oh, this is surprising. Who wants to do Impella 5.5? Anybody? Some people want Impella 5.5. Good. Probably people from Abiomed. Who wants to go to ECMO? ECMO, yeah. Okay. So we know this is the options, and I consider that we should do it with the ECMO. And this is one of the reasons why we need maybe different one. This is danger trial. I really won't go over it because everybody went over it, but this is the first trial that some temporary VAD show benefit of survival. That was a danger trial, and it's going to be a big change. And this is even Impella CP, which is only 4.3 liters of flow, comparing to our Impella 5.5, which gives even more flow and more support. And I put a different trial for ECMO because it was different. It was never finished trial. It started showing the difference. This is also from Europe via EuroShock trial. But the difference, what our guest from Europe was really emphasizing, that in ACL shock, they put ECMO after 6 hours of shock. And here they put the ECMO after 30 minutes of shock and after PCI revascularization. Unfortunately, due to the COVID, this was stopped, but there was very huge tendency for benefit in these people anyway. So, and so this is our generally situation. So routine use of balloon pump in patient with AMICs based on the data is not recommended. There may be a patients who may benefit for balloon pump. That's the reason I put them a lot, as Francesco emphasized it. But we should really consider to use Impella early and often because only data which are now showing the benefit of survival, are for Impella. Thank you so much. I tried to do it short.
This is great, and I think really very nicely illustrates how to approach the case. We have a vote. Maybe we should. So that's why raise your hand. Who the IABP decision was the right decision for a completely different case that Sasha described. So yeah, I don't think we need to have a vote. I would call it a tie. I think we both did a great job addressing patients, and the critical teaching point that Sasha made, I think, is we got to measure and remeasure and see what's really going on. But in the future, we will still consider the balloon pump, I think, first line here, and I guess hopefully we'll explore this more throughout the MA funding if it would come. So thanks both of you. Great. We'll move to the next debate, which is a little bit traditional for us to have our graduating fellows, David Lins and Fahmi Alba, debate something. And you heard earlier that whether or not the ECMO patients in the study from Germany have entered is a big discussion point. And I hope that this discussion will also illustrate why we're talking about it, what is venting, should we always do it, should we sometimes do it, and David and Fahmi are taking this on.
I'd just like to say up front that we made sure to keep our presentation nice and short to give enough time for Sasha and to tell his whole history with Francesco. I did have some sick burns for Fahmi, but we cut those out.
Anyway, all right, good morning, everyone. So David and I will be talking about VA ECMO, and David will be arguing that we should always mechanically vent patients on VA ECMO, and I'll be arguing the correct answer, which is that it depends. So I'm not going to go through too much about VA ECMO, but remember that it's a form of mechanical circulatory support where blood is shunted away from the heart, decreasing preload to the ventricles. And then this blood is put through a pump and an oxygenator and then returned back to the body. And critically, in peripherally cannulated VA ECMO, this blood that's returned back to the body is returned retrograde up the aorta against the usual flow of blood. And in patients with very sick hearts, which obviously most of our patients have, this flow from the ECMO can compete directly with blood coming out of the left ventricle. And so overall, the ECMO, it decreases preload to the heart, but also increases afterload to the left ventricle. And so this increased afterload can lead to downstream effects, including an increase in left ventricular end diastolic pressure, increased LV distension, and a decreased stroke volume. And overall, just like what Dr. Saeed was saying in his talk, this can lead to pretty significant consequences for patients, including stasis in the left ventricle of blood and also stasis in the aortic root, causing thrombus formation, putting patients at risk for strokes, myocardial ischemia from just increased LVEDP, and pulmonary edema and even pulmonary hemorrhage from increased left atrial pressure.
So next, we'll talk about strategies for unloading, and there's kind of two separate groups of strategies. There's non-invasive strategies, which are dependent on residual LV contractility, which include limiting flow or partial flow ECMO to allow the aortic valve to open, use of inotropes to help increase contractility, and vasodilators if blood pressure tolerates, although that's quite rare. And then next is the mechanical venting, which is what this talk is going to focus on. And here is the several different configurations for mechanical venting, which I'll go over very quickly. First are the transeptal configurations, whether that is active or passive unloading of the left atrium via transeptal puncture. This is the ECPella configuration, which is the use of Impella, typically Impella CP, for active mechanical unloading of the LV. This is the balloon pump for unloading of the LV to decrease afterload, as Dr. Sims explained very well. And then lastly is a direct a direct LV pigtail cannula for drainage of the LV. And so now we'll discuss kind of who should be vented. And, you know, my position would be that all patients should be vented up front, and I'll explain why. So as we discussed a couple times today, increased afterload associated with ECMO causes distended LVs by decreasing LV emptying and thus increasing end-systolic and end-diastolic volumes. And I'll show you why distension is bad in this case. This is from a paper published by Truby et al. That looked at patients on VA ECMO and looked at differing levels of distension. And as you can see here in the black, with more distension, there was less myocardial recovery. And by far the most myocardial recovery in patients that were that had no distension. But then they looked at it further and looked at survival here on the left of patients that either had clinical, subclinical, or non-distended ventricles, and the non-distended did the best in terms of survival, and further looked at the patients that eventually required decompression. And there are only 19 patients that did require decompression, but you can see overall survival of patients that required decompression was quite low, but the patients that required decompression early did better. 4 out of 9 survived, and only 1 out of 10 survived in the patients that required late decompression. So this goes to show that there is something to be said about decompressing the patient as early as possible. I know we've discussed thrombus quite a bit, and a paper from Weber et al. Published in 2017 showed that 4% of patients on VA ECMO develop either thrombi, either LV aortic valve thrombus from lack of aortic valve opening. And in that paper, no one that developed thrombi survived. And as we know, we can't always predict who is going to develop thrombus. There are some ways, but smoke's not always seen in the LV. And then also there's an increased risk with with running anticoagulation higher, as I think we all know, increased risk of bleeding, etc. So this is data from 2 separate large meta-analyses at looking at both survival and ability to wean from ECMO on patients that were vented or not vented. And on the left, in both of them, you can see that patients were able to wean from ECMO earlier if they were vented. And on the right, you can see also they noted that there was no statistical significance in patients that were vented late, but only a benefit in weaning from ECMO in patients that were vented early, meaning within the first 12 hours. And that's just blowing that up. And then interestingly, the Alfaris meta-analysis actually looked at the differing strategies and ability to wean from ECMO. And actually, the only strategy that showed a statistically significant benefit to weaning early was intra-aortic balloon pump, which I think is something that, often we think is not as useful, but this data does go to suggest that that may not be the case. And then this is mortality data from the same 2 meta-analyses. And as you can see in the blue, that is with balloon pump, and in the red, that's overall, and both showed a mortality benefit. And the Alfaris data specifically looked at mortality when you excluded patients that were upgraded to ECMO that had intra-aortic balloon pump or Impella pre-ECMO, and they had an actually even better benefit. And then again, both showed the biggest benefit with in the balloon pump groups. So Fahmi is going to discuss with you guys the risks of venting. And both of these large meta-analyses looked through several different risks of venting and looked at the difference in patients that were vented versus not vented. And as you can see here, there was no statistically significant difference in renal failure requiring hemodialysis, no statistically significant difference in stroke, although there was a slight trend in the Alfaris data to less stroke in the venting group. There was no statistically significant difference in ischemic limb, and no statistically significant difference in bleeding, although there was a trend towards more bleeding in the vented group. And this is, we have already discussed this paper today, but this is a paper from Grandin et al. That was published in 2022, looking at also registry data, almost 13,000 patients on peripheral VA ECMO. And like Dr. Saeed mentioned, there is an increase in venting that is largely been in the last couple of years that is associated with increased percutaneous VAD use or Impella use. And then they looked at the outcomes, and there was a statistically significant improvement in hospital and on support mortality in patients that were vented over patients that were not vented. And as he also mentioned, there was more cannula site bleeding and more hemolysis. But that being said, there was not a statistically significant difference in renal injury, ischemic stroke, limb ischemia, or medical bleeding. And again, interestingly, they looked at the difference between balloon pump and percutaneous VAD, and almost all of the complications certainly favored intra-aortic balloon pump, which I think we all kind of expect. And then there was a not statistically significant, but very close to statistically significant trend towards in-hospital mortality improvement with balloon pump over percutaneous VAD. So that is something that we should consider, whether when we think about all of the risks of venting, maybe we should consider balloon pump more often than we do, because it is certainly much lower risk. And now I'll pass over to Fami.
Okay, so that was David's argument for why everyone should be vented, and I'm gonna now tell you why that's wrong. The main thing is that the vast majority of studies that we have in this area are really observational studies. And I think we all remember that observational studies are really at the bottom of the totem pole for studies. And especially in these situations with VA ECMO patients where the care of these patients is very complex, it can be really difficult with these studies to accurately get rid of confounders and find, appropriately matched cohorts to actually compare. So what can we tell from these observational studies? I think that something that we can tell is what actually happens in the real world. And looking at observational studies and looking at registry data, overall, what we know is that actually only about 40% of patients were assessed by their clinical team as having indications for mechanical unloading. And it's actually really important to remember that while some studies tried to account for this, most of these studies included patients who had balloon pump and Impella before ECMO. So they weren't even really using these devices as unloading per se. So it's certainly not the case that all patients require venting. While there is a significant, very sick population that does, seems like probably many more patients that could get by on ECMO without requiring any venting. And this is really important because with a strategy of pre-unloading everyone right up front, we may be putting many patients that wouldn't require it at all at significant risk for the very real risks that are associated with mechanical unloading. So David showed you some, meta-analyses that show that there's no difference in adverse effects, but I think that just, based on our experience with what we see in actual patients, it's hard to say that taking care of 2 mechanical circulatory devices has fewer or the same amount of side effects as taking care of just 1. I think there's something to be said for the increased complexity of care and the increased resource utilization that this, takes out of the clinical team. David didn't really show you anything about hemolysis, but there is very consistent data that there are higher rates of hemolysis in patients that are mechanically unloaded who are on VA ECMO. So there are very real and potentially catastrophic side effects that can be associated with mechanical unloading. Furthermore, so if we're going to say we should not vent all patients early, is there a downside to waiting and seeing and potentially venting them later? So in this paper by Grandin, which really looked at the ELSO data, this is like the largest database, largest multi-center observational study that we have. When they looked at patients that were vented early versus patients that were matched and were vented later, in their reports, they found that there was actually no difference in mortality. So it's possible that, so, you know, basically we're not really losing much by waiting and seeing in these patients. Interestingly, there's actually 2 randomized controlled trials out of Korea where they looked at unloading with atrial septostomy, which is, you know, not something that we really do here as often. But when these are the only 2 randomized controlled data that actually exist in this arena. And I'm just showing you one of them here, but when they compared patients that were randomized to either early ventricular unloading with atrial septostomy to conventional treatment, which is basically like a wait and see and let the patient tell us kind of method, they found that about half the patients in the conventional treatment required unloading by the end, but overall there was no difference in mortality between these 2 cohorts. So really, we do not lose anything by waiting on these patients. So we can, you know, we know because of this data that we have that venting does not have to be done early. So who should we vent then? You know, the data is really kind of all over the place. I would say that there's kind of a trend in the data that potentially patients who are in this category of non-acute MI cardiogenic shock, which largely includes patients who have chronic heart failure, that maybe they would benefit the most. But honestly, most of the data is not consistent. We still don't know who we should be venting. There are randomized controlled trials that are in process that are comparing patients, you know, venting early versus ECMO alone. And hopefully these trials will shed some light onto who we should be thinking about venting. But in the meantime, I think that all we have basically is our clinical assessment. And so here we have the proposal by Dr. Yordi and Dr. Saeed, and I think that I win just because I showed this. But this proposal basically advocates for an initial blanking period of 12 hours where we just kind of let the patient equilibrate and not vent them unless there's some, you know, obvious need for venting, like evidence of LV blood stasis or evidence of pulmonary edema. And then at the end of the 12 hours, we assess 3 things. One is the aortic valve closed? The other is the pulse pressure, which is the difference between the systolic and diastolic arterial line pressures, is it less than 15? And again, this is the importance of hemodynamic monitoring in these patients, is the wedge pressure over 30? So in these situations, you know, assessing the active hemodynamics of this patient can tell us whether we need to think about venting in these patients. So in this protocol, it advocates for adding initially inotropic therapy to help unload the ventricle. And if patients are still meeting these criteria, then moving on at that point to mechanical venting. And I think this is really important because, like we just said, you know, potentially not all patients need to be vented. There are significant risks to venting patients up front. And so in the absence of enough evidence to vent patients and in the presence of significant risks, I think all we can really do is allow the patient to tell us whether or not they need to be vented. That's it. Thanks.
Okay, thank you very much. I think we should take a quick vote. All that believe every patient should be vented right away. Raise their hands. Nobody. All of you, you should wait and see if that patient is event as needed. Yeah, that's the also and Fami did show. There you did show our work class, so I would like to offer you a faculty position there. Fami can join obviously Leah and David also didn't need to win today because we already had a faculty position in Orstein from Vegas and New Jersey. So we got the both great. So okay, VR, Saeed, from Germany is going to take us home. I introduced him with yesterday, but VR is a cardiac surgeon who runs a greater heart center, is on the board of IFHT and has first authored the IFHT MCS guidelines that come out about every 10 years. So the recent one about a year or two ago Dia was the leader of the team and is first author on the major papers on how to transition a patient who finally did well on ECMO. The organs are functioning again. The patient is not at a neurological deficit, but needs support. How do you get a patient like that on a durable device or a transplant? That's where Dia is going to teach us.
Well, thank you, Uli. Ladies and gentlemen, it's a pleasure to be here again in Montefiore, and I will discuss during the coming 20-30 minutes a different kind of approach. And before starting my presentation, I have to give this disclosure. I live in Germany. That being said, I'll be presenting some approach that for you here in US may not be that attractive because you have some other options, and I'll discuss these options with you. Why some sort of therapy limitation we have in Germany kind of encouraging us to go to a different options that may not be even the better one. Let's start with this case. It's a 55-year-old male, BMI 27, dilated cardiomyopathy, had atrial fibrillation, was operated 2002, it's like several years ago with an AVR. He was coded, got a peripheral ACLS. We have now the 6th day after ACLS support. He's not vented, by the way. This patient is now intubated. He's on dialysis. White blood cell count is 28,000. We have total bilirubin of 25. Lactate is 3. All right. What's the next option? You can vote on this, and we'll back to this patient later. So the options which we have now, we have 6th day after ECMO support is to do a heart transplant for this patient, to go for a durable VAD, to do a total artificial heart, palliation, win an explant, or go for Impella 5.5.
Is it a tissue aortic valve or mechanical?
It's a tissue. Right? So I have to go back again.
I think it should go back. People can still vote, so that they can take a look at this.
All right. So, all right. And the voting will show up in a minute, I guess. Okay. 42%. Wow. Like 40% is going with, in this patient with multi-organ failure with the high bilirubin, going for durable VAD, 20% for transplant, Impella 5.5, 40%. We'll come back to this case later. Let's move forward. So, you know that Intermax 1 patient, they have the worst outcome, whatever you go with this patient. And we have a lot of limitation when you have a patient on ECMO. These patients are, many of them are reanimated. The neurological assessment is really tough. This is like the perfect patient. He's now extubated and talking to you, but not every ECMO patient is like that. The right ventricular function is tricky. The patient's on an ECMO, and the assessment of end-organ function is also tricky. And we heard a lot about the so-called ECMO-related complications. So if you wait longer, you'll get a so-called ECMO-related complication. So whatever you do for a patient on ECMO, whatever you do, even if you put in a chest drain in a patient on ECMO, you have to think about multiple times because you should expect more bleeding, more RV failure if you go for a LVAD, and more respiratory failure and a worse outcome. All right, what options do we have? Let's say we have a patient on ECMO. The first thing we want to do, of course, if every requirements are met, is to expand the patient and send him home. That's the best thing we do. Other options, if the patient is not weanable from ECMO. All of us have our weaning protocols. We tried, and the patient is not weanable. So one option is go to palliative care, just turn the machine down and let the patient die if things are going to the bad direction. The other option is the question, where you live. You live in the United States, I recommend you go for a transplant, probably. And if you live in Europe, particularly in Germany, then you don't have the option of transplanting a patient on ECMO because our waiting times in high urgent status blood group 0 is 6 months. That being said, no patient gonna survive 6 months on ECMO to get transplanted. So let's talk about the first option. I'm gonna show you a couple of papers on that option, which means transferring a patient from ECMO to transplant. Historically, outcome of patient who got heart transplantation after ECMO has been always bad. The first papers came from France. That kind of approach was more the European approach from France and from Spain. They do a lot of transplant. And this is one of the recent papers, 2017. In that paper, they showed that in a very, in very experienced centers, that the outcome, the 90-day survival or 1-year survival after transplanting a patient on ECMO is 50%. That's terrible. Another publication coming from US, transplanting a patient prior to the new allocation system, 60% 1-year survival. In that paper, they compare Impella to transplant versus ECMO to transplant, and they conclude that Impella to transplant patient will do better than ECMO to transplant. The most recent publication, also from US, very encouraging, and I think, in my opinion, is the patient selection rated, is that right now, with the new allocation system, you guys are achieving 180-day survival of 90%. That's amazing in an ECMO patient. So the question is why? Early patient selection, early ECMO implantation in a patient that probably not that bad for ECMO. That's really a good option. So put it this way, we cannot do this in Europe. I cannot do this in Germany, but in US, it's possible to transplant a patient on ECMO, but you have some limitation. I just put one of the pictures. There are 3 leaders in the field. Snehal is sitting here, and Emma Burrs and Stavros. So that option of transferring a patient from ECMO to transplant will exclude them from weaning and recovery. Even though there are 5% of the patient, there are still patients who got LVAD, they will get weaned and explanted. And in an experienced centers who got protocol, they may end up explanting even more patients. And so recovery, especially in the neck, like a 25-year-old patient who got a transplant, you know that about the New York Times article, that's really, I mean, most of us like to get transplant on a VAD, but in that particular patient, probably recovery will be the best way to go. That being said, if I would conclude, transplant from ECMO is really good. You guys are achieving great outcome, but it's all about the patient selection and limitation for recovery. Let's go to the different story, which is like the stuff which we do on a daily basis in Germany, transferring from ECMO to VAD. So when is to bridge? That's the question of my my presentation. When is the best time to bridge? So whenever you have a patient on ECMO, whatever you do for this patient, even though if you transplant the patient, I think the approach is pretty much the same. You need to preoperatively optimize the patient. And here in US, as far as I know, you guys have like 7 days of waiting time for transplanting a patient on ECMO. We can schedule our VAD days. For example, let's say I'll do the VAD next week, even a patient on ECMO, but I need to optimize the patient. So preoperatively, then optimal patient selection and intraoperative approach. So there are 3 ways of getting the optimal outcome in these patients. What do I mean with preoperative management? There's a lot of like steps that you need to do so that patient will be getting ready for the OR. Antibiotics, avoid, give inotrope, vent the patients. So we vent a lot in our patients, and we give vitamin K, we try to get the platelet values high, and then aggressive diuresis. And one of the things that I believe you don't have it in US is the option of giving levosimendan therapy. We do that like 48 hours prior to the procedure. You have the patient on ECMO, we give them levosimendan, and 2 days afterwards, if things are getting better and we are thinking that the patient's on the right timing, then we go for a durable VAD. So this is one of the first papers showing that venting. We heard about venting, that venting in ECMO patients is good. This is another paper from ELSO. It's another meta-analysis showing that any sort of venting, even with a balloon pump in an ECMO patient, you will achieve a better outcome. With that, you manage your patient. It's a paper about here, levosimendan therapy. It's a retrospective study, it's an observational study, but still it's showing that levosimendan group, they get better outcome if they get patients on ECMO compared to those who did not get levosimendan. Again, it's not a prospective study. Right, so let's say we prepared our patients. It's ready to go. We pre-have the patient. fine tuning is done, neurologically intact, we know what we do, and now come the next step. What's the best timing and how you select the patient? This question came up in our mind like in the 2018, 2017. At that time, we made the so-called durable MCS after ACLF study group. It's a multi-center register study, including all patients who underwent durable VAD therapy after ECMO. We end up having 533 patients. When we published that, it was the largest study, including ECMO patient, and we end up getting some predictors of survival. And here are the predictors: age, female gender, high BMI, previous cardiac surgery, AFib, lactate value, bilirubin value, and renal replacement therapy. With that, we made the so-called durable MCS after ACLS calculator. It's a free app. You can download it on any of your cell phones, and then you give this stuff, and then you will end up with some sort of estimation of 1 year survival in this specific patients group. And to move forward, we did a validation study. In that validation study, we included some other centers, and we had at the end, we presented this data at the ISHLT meeting. We have now 163 patients, which was involved in the validation study, and we found out that the predictors was really good. It's not perfect, but like any other predictor, it was good in predicting the outcome and 1 year survival in this specific group of patients. So back in days, 2018, there were not much Impellas around. So there were Impella CPs, but venting was not that big deal. Right now, everyone's talking about venting. And now we have the so-called Impella 5, Impella 5.5. So right now, during the last, say, couple of years, there is now the new option, the so-called bridging from bridge to bridge. What that means? So we have a patient on ECMO, used to go to durable VAD right away. Now we have another option. We go to another step prior to go to VAD, to go to Impella 5.5 and keep the patient unloaded, train your right ventricle, and then you go to VAD. All right, advantage of direct VAD is the final solution, no additional procedures, and you have probably lower risk of neurological complication and of course cost. Disadvantage of direct VAD therapy, you may need more temporary RVAD because you don't know about your RVAD. I've been implanting LVADs in patients, which actually, obviously you thought that the right ventricle is good and echo, but it's not ECMO. So when you put the LVAD in, they will get that RV failure. So again, you exactly know about the right ventricle when you come off the pump. And of course, poorly managed cases will make your center outcome doesn't look good. So how about pro-Impella? The advantage of pre-Impella is you will win time. If the patient's neurologically not intact, CT scan is okay, you don't know anything about the neurology, you buy time, you put it in, and you wait until you see more about neurology. And you train your right ventricle. That's the way that people tell sell it. And you optimize your lung function. You don't have this retrograde flow, and you optimize an organ function. What are the problems? If you go to Impella and then to VAD, stroke risk, questionable, probably you'll get more stroke. You have two mechanical supports. You probably will get more interstitial bleeding, more bleeding complication. We heard about hemolysis, infection, and of course. Let's talk about the outcome. This is the outcome from the multi-center study, which we present. And the 1 year survival was 55%. Like almost half of the patient died after 1 year of implanting durable VAD after ECMO. That was the data included until 2018. How about the validation study? You see, we improved the outcome from 1 year survival 53% to 67%. Why? Two explanations of this. First of all, and the best explanation, we selected patients better. In my center, patient which I used to do LVADs in durable VAD, I stopped doing it because I thought that patient not gonna survive. Regardless of the age of the patient will not survive if he meets some sort of criterion. The other thing is, to be honest, one of the explanation is there were more HeartMate 3 implants in the group. So that's why probably there were less strokes. And we didn't look at the subgroup analysis, but the survival was better. That was the European study. How about the Intermax data? This is the IMAX data, looking at 1,000 patients who underwent durable VAD, they were 20% of the entire population after ECMO. The outcome is similar. The 1 year survival was also about 60%. So with that, European and IMAX study, which also included European data, we are around 60% when survival. And this is another publication from STS Intermax database. And interestingly, the outcome 1 year survival, if you implant a patient after ECMO with a durable VAD, around 66% 1 year survival. So with that, it sounds like we cannot achieve more than 60-65% 1 year survival in these patients population. And one of the things I like about this paper is they look, if you do propensity score analysis and you match the groups, being on ECMO is not per se risk factor of death. So the ECMO factor, ECMO is not the predictor of the death. So how about the Impella strategy? This data is not published, it's under review. This is a multi-center European register study looking at the patient who underwent LVAD implantation after Impella. Not direct implantation, they were patients with Impella. And from this group, they have 40% Impella. What was the survival? Actually, I was surprised, 70%. I was expecting better survival. And then we match the group. If you match the group, Impella versus ICMELA, there is a trend toward better survival if you have Impella to LVAD, which actually you think that you selected the patient better. The Impella group, ICMELA group, which was they were patients with ECMO plus Impella, did worse, but the survival advantage is not that great. What about other complication? In our registry, durable MCS, durable LVAD after ECMO, RV failure, 40%. Like from 10 patients, 4 of them came out of the OR with BIVAD. That's a lot, right? In the validation study, didn't change much. The RV failure was pretty much similar. Bleeding rethoracotomy, the recent study shows 27%, like 1/3 of the patient go back to OR. There is like not such significant difference, but the complication appears to be the same. How about the Impella strategy? 20%, that's very surprising. Why should a patient who is on Impella alone go to OR and come out of the OR with a BIVAD? That was surprising to me. Like 1 from 5 patients in this registry who came to OR with Impella end up having a BIVAD afterwards. Bleeding requiring rethoracotomy exploration was less. That was really weird because I was expecting to have much better survival in the Impella group because we thought that we selected the patients better in this group. Stroke risk, in the registry, we found that almost 1/3 of the patients who underwent durable VADs after ECMO, they will get a stroke. That's a lot compared to the regular patients population who will get the LVAD therapy. Stroke rate in ECMELA VAD group was 0.126. It's comparable. Again, this is not not a comparison study. So what I was trying to say is, I think not every patient need to be bridged. I'll give you this example. This patient is 55 years old, BMI 27, dilated cardiomyopathy. On the 6th day of the ECMO support, we have, in this case, good lung function, liver function test is fine. The values are okay. Right ventricle looks okay. He's on ECMO, neurological intact, and the renal function is okay. So let's vote for this patient. What are the options? Transplant, durable VAD, bridge with Impella first, and then do for LVAD, or renal explant. Move back. So remember, dilated cardiomyopathy. So this patient have a long history of heart failure. This is something I need to highlight. He's now on an ECMO, decompensated. So that kind of patient, we went for durable VAD right away. I don't know how is the outcome of the swipe again. Right. So you see, that's great. So the majority of you guys think that in a patient with a long history of heart failure, who's now on ECMO, everything looks okay. We perhaps the patient's well. Why should I go with the Impella first and then do LVAD, it's a procedure in between. Go ahead and do direct LVAD right away. Again, this is if you live in Europe. I assume probably in US, you may end up just transplanting the patient, just to highlight that's important. The other patient, look at this one. Acute myocardial infarction. This is an acute story. CPR in the cath lab, ECMO, 6 days afterward. Same thing, same patient, 6 days after support, but an acute MI. It's not a, let's say, it's not a chronic heart failure. How we work on this? Same options we have. I need to swipe this and so on, and then showing up. Yeah. Wean and explant. So majority of you are for wean and explanting the patient. In this patient, is weaning was not possible. So what we did, we bridged them with the Impella 5.5, waited like 20 days, explanted the Impella, things went well, patient was discharged. So again, I mean, the Berlin group implant Impella in every single comers. I don't think that's the way I want to do it. I probably think that there are some specific patients, especially acute MI. These are recovery patients, right? Again, that patient will go for recovery. So to transplant this patient may be a good thing, but I'm not sure if that's the thing I want to have, especially if I have the possibility to recover. So how we do this, let's say that's the last part of my slide, my talk. So let's say we optimize the patient, we selected the patient as well. So what are the tips and tricks which I would recommend based on our experience with this large number of patients who underwent durable VAD therapy and ECMO? There are a couple of things. One of the things we thought the video is not playing. So what we would do is we implant the patient on ECMO. We implant the LVAD on ECMO. We will not switch the patient to CBP. That was previously possible because we were using the Corin tool. Danny, he's not around. So we were using the Corin tool of Heartway HVAD to do this procedure. With the HeartMate 3 Corin tool, this procedure is really tough. But again, what we did, we matched 175 patients versus another 175 patients, and we found out that the outcome is same in the both group, but you will have much less bleeding complication, much less blood transfusion requirement if you implant the VAD on ECMO without transferring the patient to the cardiopulmonary bypass. The other thing is, you guys heard that from my talk yesterday. We are a minimal invasive center, and we do also almost all LVADs minimal invasively, and in this group, we found that in this multi-center study, the less invasive implanted LVAD on ECMO did much better in outcome. So the last option, by the way, this is the way people used to treat headache, 1871. So the last option, we need to talk about it. I think it's outdated. So, but this is a paper from Columbia Group. Uli is also one of the authors. So what they did is they presented the so-called temporary LVAD therapy, so surgical LVAD temporary. And if you look at the outcome also from patients who were from LVAD, they had like 1 year survival of 48%. So with that, what I is here trying to say is, in this case, you don't bridge with Impella 5.5, you don't bridge right away to durable VAD, you implant surgically, externally located VADs, and then you go further for the next step, let's say transplant or durable VAD. But I think this, I don't know if Columbia or you guys are doing it here, but this is kind of outdated, but I thought that to talk about it as well as an option. So let's go back to our first patient. You remember 6 days after ECMO, intubated, renal failure, dialysis, total bilirubin and lactate value. So this is the last voting. Oh, it's not, you guys already voted, right?
Not on this one.
That was the beginning. Right, it's really important to know. Yeah, they voted on it. It was like 40, yes, 40% were for durable VAD. I remember that.
Vote again.
Yeah, let's vote again. Let's vote again. Show me slide.
Right.
Now, oh. One more time. Yes. So that was the previous vote, or is that the new one? This is the previous.
This was the previous one.
Yeah.
Now we'll go.
You're almost done.
Take challenge.
1 second. Now it's new one.
That's the new one.
Yeah.
So after hearing all of what I talk about, you have a patient with renal failure, dialysis, liver failure. What are we doing about this patient? You remember, we tried everything in this patient. That's the best of the patient, right? But still, we have a bilirubin of 25 milligram. He's on dialysis. So, let's show.
Yeah.
Yeah, durable VAD's getting less, and still there are people thinking about transplant. So what we did in this particular patient, yeah, you guys are preachers. So we did, we calculate the outcome based on our app, 16% survival, 1 year survival. So what we did in this patient, he was a little bit young, but still we went for a palliation therapy, and the patient, he didn't get any VAD. So to conclude, preoperative and intraoperative patient selection optimization will improve the outcome. It's all about patient selection. We learned that a lot. We heard that a lot today. Durable MCS after ECLS calculator, which will help you out in selecting your patient again for durable VAD. This calculator works for durable VAD therapy. It does not work for transplant. But pretty much, if we look at the data, it's like liver, renal function, it's a MELD score. So it wouldn't surprise me if that calculator would also work for transplant candidate. Another study idea, probably here in US. Without CBP and minimal invasive approach will minimize your postoperative complication. Bridging with Impella, based on these observational register study, does not seem to improve the outcome. Outcome pretty much the same. And complications are comparable if you do with Impella versus if you do just for LVAD, and bridging with ECLS to transplantation is almost impossible in Europe. I will say Germany. With that, based on body mass index of the patient, blood group, we discussed that yesterday, and the continent, you live in US, Europe, bridging to transplant may be the better option. Thank you very much. It's lunchtime.
Yeah, that was perfect. Thanks so much. Any questions? Yeah, Omar, yeah.
Great talk here. No, I really like the point you made about patient selection. And although these bridge devices are used more often, I think in some of this in your slide and this gathering, I think it's the other organ recovery that's a bit of a wild card here. So it's not just the heart.
Right.
You have to see what state the other organs are in, and decide if the patient eventually going to be a candidate for something. It's sort of is the conversation, what is the ultimate destination for the patient? We don't want to leave until we have a lot of patients with on these intermediary devices, really just something that seems to do without any explanation. So how much do you guys consider that when you are making a decision? One question, and you also showed your, your validation cohort that the data has improved, survival data. But in the ECLS study, it still seems like ECMO to LVAD is used very, not often at all, very few patients. And I think that is the ultimate destination, get them on ECMO, but the patient may not do well because the more downstream options will not be considered. I just was wondering why that research was so low.
Right. Again, we decide based on availability, and durable VADs, implants in ECMO patient, this is particularly in Germany. We have the largest VAD numbers are in Germany, as well as ECMO numbers. But for example, in Spain, they transplant the patient. And I think most of the patient, when they get transplanted, then they will get a transplant or they will kind of get palliation, because durable VAD therapy in Spain is very, very low. Same applies for France. So I think it's about when if you have the possibility of transplanting a chronic heart failure patient on an ECMO, I would go for transplant in this patient. But again, because of the limitations we have in Europe, we have to go for durable VAD. But what we learned now is to select the patients better. And that's what we learned. during the last, let's say, 10 years. We used to implant in pretty much everyone. And nowadays, for example, having a patient after ECMO on dialysis, only renal dialysis, because of renal failure, acute renal failure during the shock period, that's not an exclusion criteria. Talking to some of the friends here in US, I hear every now and then that having a patient on dialysis may be an exclusion criteria for a durable valve therapy. But based on our experience with durable valve therapy after ECMO, to have only dialysis is not a problem. The problem is the rest, again, it's like the liver function, particularly the renal function. You have also infection parameters. And if you look at the parameters, there are some modifiable and some non-modifiable. The non-modifiable is the age. If you have an older age, a female gender, you will do bad. So you cannot change that. But what's changed and modifiable, and probably the scoring system, the trend is important. If you do this calculator today and do it next week, you'll get different results, because if the liver function gets better, the renal function gets better, if the infection parameters getting better, then probably the survival rate is better in this patient. So there are some modifiable criteria that you kind of look for and try to adjust and select your patient accordingly. Hope I answered your question.
Thank you.
Yeah, excellent presentation. I wanted to ask about the levosimendan, because we used it before as a bridge to LVAD, but then we stopped using it because sometimes you get a lot of vasodilatation after the implant. So we kind of switched to, methadone or something you can actually wean off. What's your opinion on that?
Right. So we used to use it for LVAD implant patients, but we stopped doing this. Why we stopped doing this? Because I personally did not thought that it's like advantages. And what we were doing is we do it only for ECMO patients. Why we do it for ECMO patient? We do it just for the right ventricular preparation. Of course, you can do it also for regular LVAD candidate, but we do it, we have to make sure that the last dose of levosimendan and at least 48 hours prior to the procedures. So this is something that we learn. If you do levosimendan and then you go to OR, the patient will get a massive vasoplegia. We avoid that. And the other thing is, so we try to make sure that the levosimendan dose, the final one, is done. You have 48 hours, because the levosimendan therapy theoretically will stay in blood for 7 days. So the inotropic advantage of levosimendan is 7 days. With that, if after the second days, you are in a good shape to go to OR without having this vasoplegia issue. And we do this only for ECMO patients, but we don't do it for regular VAD candidate. Regular VAD candidate all get Merinon and diuretics and vitamin Ks and all of that stuff, and then that's how they go to OR. And again, we do almost every LVAD, we do minimal invasive also in ECMO patient. And the minimal invasive is a different story, it's a different talk, but I think the advantage is not because of the incision. The advantage is the CBP time with minimal invasive is much less than regular, because you do not fixate the heart. The heart stay as it is, you do the cuff on it without going on pump, and at the timing of just the time when you do the coring tool. Other than that, you have like very low CBP time. With that, the patient comes to OR, get the VAD, get out of the OR, they do much better. That's our experience. Danny.
Great, thank you. There's one option that you didn't cover, and I wanted to get your thoughts on it. The concern in going from ECMO to LVAD is always right ventricle, right?
Right.
And all you showed on the case scenarios you showed, either one with a liver dysfunction, you only put in Bell 5.5. There's another option, which is bipella.
Right.
So, what are your thoughts on bipella? Bipella means you have an Bell 5.5 and you have an Arbella or Protec Duo on the right for 9 days, so you don't have to open the chest. What are your thoughts on bipella versus ECMO? Because you preserve mobility. I think you walk around with something here.
Right.
You have full support as long as your lungs are fine. In theory, that seems like a more attractive option as a bridge to leading RVAD to solely developed by virus to transplant or world development.
Right.
So some thoughts about that.
Thanks, Danny. It's a good point. So the question is about bipella. So Impella 5.5, absolutely, but the Impella RP is not we don't use that. We use that a couple of times because of the dislocation of the impeller. We stopped doing it, but we do a lot of Protect Dio cannula. I'm also a big fan of this, particularly if you do, I mean, this question may rise up if you do minimal invasive VADs, how we do an LVAD implantation. So what we basically do, all of the patient will have a swan. If we end up with the RV failure, we just switch the swan to a Protect Dio. And I totally agree with you. And I think one of the explanation of getting a better outcome during the recent years in the validation study was, one of them was based on patient selection. I think that's what the most important. The other one is pump, more heart rate 3. And the third one is probably in my institution, anyone which we thought that probably the right ventricle will be bad, we'll put in a Protect Dio cannula inside. And then expanding on the ICU was really, so we were much more aggressive. That's why if you look at the numbers, the RV rate implantation did not change with time because we were more aggressive in this group. The new beta selected group, we were more aggressive with RV therapy with a Protect Dio cannula. So I'm a big fan, and I think it's a very good option because it's really very easy to be done, and our anesthetist is doing it. I mean, that's the good advantage. We don't have to go to OR for that. So the anesthetist is doing it, and they implant the Protect Dio cannula, and you expand on the ICU. Is really a good option.
So two comments about that. One, the new RPL doesn't go through the groin, goes through the IJ. I don't think you have that in Europe.
We don't have that, no.
So that's an option.
Okay.
Obviously, the same problem with Pro, you have an oxygenator capability.
Right.
The other thing
You guys use it here, the Arpella? Through the...
We have not the femoral Arpella we have used a few times and abandoned.
The same we did, but the new one.
IJ Arpella, I don't believe it's just.
But
it's on the shelf.
You have experience with that? It's good.
No, I think we just got it on the shelf.
Okay. Again, I don't have experience with that.
The other thing that we do that cardiologists are very nice to me about is every pre-op LVAD patient goes to CCU for at least 24 hours for optimization, and I ask them to put a swan on the left side.
Okay.
So you don't have to lose the swan.
Good point. We do the same. Make sure that the right side is free and the right groin, because for the mixed minimal invasive, we can do the right groin. So the right groin and the right side of the neck is always free when you go for LVAD therapy. That's the same we do here because of this.
Great. It is time for a maximally invasive coffee break.
All right.
But I want to thank you. I want to thank you first. It's so wonderful to get the perspective. Also, Joe asked one of the questions from Spain to get your perspective, different practice environment, different things you learn. And thanks for sharing your wisdom with us today.
Thank you very much for inviting me.
Thank you very much. Yeah, Cool. Okay, everybody, let's get seated. We're going to start the last session. So when all else fails.
How many people have on Zoom?
95.
That's amazing.
Yeah, 425 total registrations. Great. We're going to start back up in respect to the 95 people still on Zoom that want to hear Dr. Patel. We have actually a total of 425 registrations, all told, throughout the past 2 days. We start the last session. Snehal, I think will introduce himself through this lecture, but really has done an amazing job with our transplant program that he leads, and will just show us where we stand and what he has done. Thanks, Snehal.
Thanks, Uli. Just before I get started, I wanted to give a quick shout out to Dr. Yordi for putting this amazing 2 days together. It looks easy, but I know he's been working really hard for 6 months, and all of these different topics that we've gone through, he's actually mentored each of us over the last 10 years to really get to where we are. So just so you know, we all appreciate that. So I am starting today heart transplantation in 2024, Back to the Future. One of the great things about this conference is that each year, Dr. Yordi sticks to the basics, but also puts a little twist on it. And the way he puts on a twist is he gives us a different title, and it's like, basically go figure out what that means. And so this year, mine was Back to the Future. I don't have any disclosures, so I had to do my research. And as a child of the 80s, most of you guys know this movie, Back to the Future, and it stars Michael J. Fox. And I watched this movie, I watched the second and third one just to get an idea of what he wanted. And I'm gonna go ahead and start with an audience question, see how much you guys know. How do I do this? 3 fingers. So, there you go. What was Michael J. Fox's character's name in Back to the Future? Is it A, Biff, B, Marty, C, Sasha, or D, Fletch? Let's see. All right, I'm gonna cut this and keep going here. Oh, how do I get the all right, you guys got it right. That's right. Yeah, it's Marty McFly, and just so you guys get the idea of the story. So he's a kid growing up in the 80s, and this is the eccentric Doc Brown who makes a time machine. And Marty takes it back in time to 1955 to try to correct some things so that his family can grow up to be more successful. So I didn't really get any hints for this. I'm thinking I do a Google search, heart transplant 1955, nothing comes up. But the best one I could come up with is this, which is actually something I didn't know, was that the very first heart transplant in man was done in 1964. And this was done at the University of Mississippi. And this was actually a chimpanzee to human heart. I was actually not aware of that before this talk. And as you guys heard yesterday with Dr. Goldstein's talk and some of the other talks, there hasn't been a ton of progress in transplant, huge excitements, but probably the thing that we've been most excited about over the last few years is this. And this was a case report from the University of Maryland where they took a genetically modified porcine heart and transplanted it into a human. This was in 2022. And with that, I kind of came up with the idea of my talk. I wanted to start with Back to the Future, the history of heart transplant, and is xenotransplant the future? And then bring you back to where we are right now, briefly go through the logistics of the current allocation system in the United States, and talk about the MonteHeart heart transplant program. So, as I mentioned, this is James Hardy, in 1964. He transplanted a very sick individual with a chimpanzee heart into a human. Unfortunately, that patient didn't make it out of the OR when, as he described, the smaller heart could not accommodate the recipient's venous return. It's possible that this was also hyperacute rejection. We're not sure. But this was actually a great paper. And for anybody interested in the history of heart transplant, it goes through a lot of not just the medical and surgical stuff, but some of the legal and ethical challenges of doing this. And as he writes, a heart transplant operation in man was preceded by extensive studies in animals, and it had been planned to use a human donor heart, but such an organ was not available at the moment. The patient went into terminal collapse due to severe coronary arteriosclerosis and hypertensive cardiovascular disease. Thus, the heart of a lower primate was used and inserted orthotopically in 45 minutes. And the second human heart transplant was actually the one that we think of the first, and that was the human to human. We talked about this at points during the conference. This was done by Dr. Christian Bernard at Cape Town. There was a hope that Dr. Norman Shumway at Stanford, who had pioneered a lot of these techniques, would do the first one, but Dr. Christian Bernard beat him to that, and he transplanted the heart from a 25-year-old female who died in an auto accident to a 55-year-old with end-stage heart failure. Unfortunately, that first patient died in the first 18 days from a pneumonia, but the second transplant patient survived 19 months, one that he did very quickly afterwards. If you look at what happened as people were simultaneously pursuing cardiac xenotransplant, the results were dismal. You could see 6 or 5 cases here using chimpanzee, sheep, pig, but nobody really made it out of the operating room. All of these patients were dying of hyperacute rejection at the time. In contrast, the survival after human heart transplant skyrocketed and improved quickly over the next couple of decades. To take you through some of the important stuff, in the mid-1970s, there was an increase in the donor pool, which changed the availability of heart transplantation. And this was with, in the United States, the legalization of brain death by the Supreme Court. So now there are patients whose organs were functioning, but they were officially dead. And it was easier to obtain organs for donation this way in a timely manner. We learned that cold preservation of donor hearts could be achieved. So the recipient and donor did not have to be co-located. You could actually explant the heart, put it in a bag of ice, and transport it to the transplanting center. And also at Stanford, they developed a percutaneous technique for endomyocardial biopsy. We're no longer guessing rejection off of an EKG, and we really knew when to treat with steroids rather than antibiotics. Probably the biggest improvement in survival after human heart transplant, Dr. Goldstein alluded to this yesterday, was the introduction of cyclosporin. It was first used in clinical trials in the 1980s at Stanford, and because of its incredible success, it was incorporated by the FDA in 1983 and became the foundation of all immunosuppression going forward. Some minor improvements over time was the incorporation of tacrolimus and mycophenolate, and that brings us up to the current. This is ISHLT registry data looking at 127,000 heart transplants, and you can see that the median survival is now 11 years. And this is an incredible achievement when we talk about people that have days, weeks, and a few of them months to live, and now we offer them survival of 11 plus years. And it's not just survival, it's quality of life. There's a lot of different ways to look at this. This is a simple cross-sectional analysis where we ask transplant recipients at 1, 3, and 5 years, how much activity limitation do you have? And 90% of them say at each of these points in time, there's no activity limitation. So an incredible therapy, both for quantity and quality of life. But I'm going to ask you guys a question. How many heart transplants do you think are performed in the United States each year? 1,000, 4,000, 25,000, or 100,000? Let a couple of answers come in, and then we can keep going. So here we go. Oops. Yeah. So actually, most of you guys got this right. This is 48,000, 4,000. So this is the heart transplant volume in the United States over the last 20 years. If you start at 2008, a little bit more than 2,000 heart transplants. And if you go all the way to the right of the screen, you'll see that we achieved over 4,000 heart transplants in the country in 2022. So it's notable that the volume has increased. I showed you some of the reasons here, but this is still an epidemiologically small therapy. It's not affecting a large number of individuals. when you look at different estimates, 100,000, 250,000 people that could benefit from a heart transplant, we're not touching many of them. And what's the reason for this? It's strictly driven by donor organ shortage. And as physicians who want to increase this therapy, we're thinking about how can we expand the donor pool? And there's really three ways to do it. One is to increase the number of organ donors. And there's different ways to achieve this. This is really in public health policy, thinking about conversion to an opt-out system instead of an opt-in system. And that's thinking about your license. When you go to the DMV, you say, yes, I want to be an organ donor. Well, what if the system changed? And maybe Joe can tell us afterwards how this went. And I think that this happened in Spain 10 plus years ago, where you were automatically considered an organ donor unless you said, I don't want to be. The second thing is to focus on the recovery rate. This is something that Dr. Madan's going to go over. But right now, only 1 in 3 donors or organs that's offered for heart transplant is actually placed. Part of that is for good reason. Part of that is we just don't know what's acceptable or not. And that's something that we have to tackle. And the third thing is xenotransplant, right? What if we can create an unlimited supply of organs through cloning animals that can be used for human heart transplant? I will show you what's happened. The first 5 cases I showed you, since then, there have been other attempts. Probably the most famous one was baby Faye, and this was in the 1980s at Loma Linda University. At the time, a newborn infant was born with a fatal congenital disease. There was no organ donor, traditional human organ donor available for her. So they transplanted a baboon heart with the idea that when she grew and an organ became available, they could retransplant her. Unfortunately, she died at 20 days, but did highlight a lot of the issues with organ shortage. There have been a couple of other attempts since that time, up until 2022, where the University of Maryland, as I mentioned, transplanted a pig heart into a human, which actually survived 2 months, which is the longest we know to of date. There are a number of barriers to xenotransplantation. There's the obvious immunological barriers of transplanting a non-human organ into a human. There's infectious barriers. There's a number of zoonotic viruses that are unique to the specific animal that humans haven't been exposed to. And if you transfer this over during the transplant process, these infections the human body would not be able to fight. And this is actually a big challenge in it. There's obviously physiological barriers, and this is we don't know how some of these hearts and organs are going to respond when they're exposed to human growth hormone and other things. They could actually grow too fast. They could not grow enough as is expected. There is certainly social and ethical barriers. What are the legal regulations? How does it work in the allocation system? Animal rights come into this. And finally, something I'm always worried about is what about healthcare resources? If this is actually successful, are we going to do 100,000 transplants in a year? Because that could really break the U.S. health system. So let me just take you through a little bit of how we came to where we are with human transplant. Many of you guys are aware of Dolly the sheep. She was very popular in the 1990s. And why she was important, she was the first mammal that was cloned from a single adult cell. So it was shown that a single grown mature adult cell that was taken from a mammary gland could grow a whole animal. And they took the cell nucleus from this adult cell and transferred it into an oocyte that had its nucleus removed. So there's one DNA in there. It was triggered to replicate, and then the embryo was transferred for gestation into a surrogate mother sheep. The company that sponsored this process at the time was PPL Therapeutics and is now called Revivicor. And why do we care about Dolly the sheep? Well, prior failures of xenotransplantation, we think were caused by hyperacute rejection, mainly caused by this carbohydrate protein alpha-gal. And alpha-gal is expressed in almost all mammals, except in twist of fate, not in humans. So humans develop natural anti-alpha-gal antibodies. So once they see this, they're going to attack any organ that's placed in and reject it. So using CRISPR technology, they genetically modified adult human cells to remove these genes so that when they create clones similar to the process with Dolly, they will not express this alpha-gal protein. And it will hopefully at least decrease the risk of hyperacute rejection. Interestingly, it's the same company that is still making these animals. It's called Revivicor, and they actually received FDA approval for therapeutic use of these animals. And what they've created is this 10 gene edited pig. The 4 genes that are knocked out are shown on the right, alpha gal and others like that. And then they actually knock in 6 human genes to help downregulate the complement system, which is important in rejection. So what happened at the University of Maryland, they had a 57-year-old male. He had an end-stage non-ischemic cardiomyopathy. He had been on VA ECMO with no way off. And this individual had a history of medication non-compliance. He had been in bed for 3 weeks. And they, for this reason, turned him down for advanced therapies, whether it was transplant or LVAD. Since he didn't have any options, we all do this in the field. He called, they reached out to 2 regional centers and 2 other national centers to see if they would take on this case. They all said no. This is something that we all do. So they came back to the patient. They said, hey, listen, we can take you off ECMO. You're probably going to die. Or you can consider this experimental treatment, which is to undergo xenotransplant. The patient agreed. And they mentioned that the FDA had to evaluate and improve this based on their preclinical experience with cardiac xenotransplantation, the consent form, and the plan for surveillance and prevention of zoonosis. They obtained one of these 10 gene edited pigs, which apparently are cloned in a factory right outside the DC area. And after 43 days of being on ECMO, they transplanted this porcine gene edited pig heart into a human. The individual had a long post-op course. His ejection fraction was preserved throughout, but he developed severe hypertrophy of the myocardium that towards the end became so large that he could no longer fill the heart. They're not exactly sure what caused this. Some questions of whether it was antibody-mediated rejection, infection was related to IVIG he had, but either way, it was no longer viable and they withdrew life support at day 60. They quickly actually did a second porcine to human transplant at University of Maryland. This individual also only survived 49 days. They haven't provided details yet of the autopsy report and what they had happened, but I think it's something that we're going to be looking forward to hearing about. But this is happening. It's happening in a lot of different ways. This was in the New York Times a couple of months ago. This was at Mass General. They used the same genetically engineered pig. They transplanted it into a dialysis patient that was not a candidate for renal transplant. He started making urine. He actually went home. Unfortunately, this individual also died after a couple of months, the details of which are not clear. But I will tell you that there is a lot of talk that people are considering clinical trials for patients that don't have any other option. Just like Azim talked about with TAVR yesterday, not for people with traditional options, but people that have no other option. And I don't think that any of us should be surprised if we're talking about clinical trials for this in the next 2 years. So with that, let me take you back to how things stand in a heart transplant right now. This is the logistics of heart transplant that we go through. There's an evaluation phase, a listing phase, and an allocation phase. Let me just take you through this question. And it is which of these 4 is not a candidate for heart transplant? A 69-year-old with diabetes and severe coronary artery disease, a 20-year-old female with dilated familial cardiomyopathy, a 55-year-old with well-controlled HIV, or a 35-year-old female status post-recent mastectomy for breast cancer. Okay, great. I think that a lot of you understand what my point was here is that during the evaluation process, we are thinking about one thing, and that is that donor organs are a scarce resource. So we have a ethical and moral imperative to allocate these organs appropriately. And the only one philosophy that we follow is that we want to make sure the patients with the greatest need and the greatest chance to derive the maximum benefit are given these organs. So it's not about age, sex, race, anything else. It's about who's going to live 5, 10, 15 years with the transplant. And we do an extensive evaluation that includes medical, surgical, psychosocial, and other conditions that would preclude extended survival after transplant. So somebody who has cancer, was recently treated, and we don't know if they're in remission or could come back, they are not a transplant candidate at the time. So that is the only goal of our evaluation process. Some of the important contraindications for transplant I've listed here: age. We here tried to look more at physiological age than chronological age, but if you want a strict cutoff, we say about 70 to 72. Extremes of BMI, irreversible renal failure, malignancy, or non-compliance or inadequate social support. So somebody that can't really follow an intense medical regimen that you need to be successful after transplant. CMS mandates that we have a weekly selection committee meeting, a multidisciplinary heart transplant selection committee. We here meet on Wednesdays at 7:30, and we try to come together and determine who should be listed for transplant. And it includes all of these different disciplines: cardiologists, surgeons, psychiatrists, pre and post transplant coordinators, social worker, financial, nutritionist, pharmacist, and we make a group decision. So not one person can individually decide who can be or who can't be listed for transplant. And if you make the list, what is the transplant list? Well, this is kept by the United Network for Organ Sharing, or UNOS. So they were established in 1977, and they were contracted by CMS to manage solid organ transplant in the country. They divide the nation into 11 regions, which are further subdivided into organ procurement organizations. The one in New York is called Live On New York. You've maybe heard that. These are the 11 regions. We're region 9, which is in the pink up in the New York area. And when you are put on the list, it's a UNOS software that says that you're waiting for transplant, and we have to pick a tier or status of how sick they are. And these are check boxes. There's no cheating it. You actually have to meet them. And there are 6 statuses that I've listed here. Number 1 is VA ECMO. Number 2, I want to highlight is most importantly balloon pump or percutaneous MCS. And it's not just that you have this, you can't put a balloon pump in me and I'll be status 2. You have to meet hemodynamic requirements. These are the definitions that Dr. Saeed put in his hemodynamic top for cardiogenic shock: blood pressure less than 90, wedge greater than 15, index less than 2. Status 3 is continuous IV inotrope in the hospital. Status 4 is a stable LVAD or inotrope at home. Status 5 is multi-organ transplant, and 6 is everybody else. I want to point out a couple of things is that all of these statuses are actually determined by the therapy deployed and not necessarily the objective severity of the illness. So we haven't been able to find a better way. So if you are on ECMO, whatever the reason, you are status 1 for transplant. And status 1 to 3 have to be hospitalized. And if you look at who is being transplanted in the United States, you'll see that 75% of transplants are occurring in status 1 to 3 in this country. So essentially, if you think about it, you have to be sick enough to be in the hospital to get a transplant in this country right now. This will change in the next 2 years. We're collecting data, or UNOS is collecting data on a number of different characteristics of these patients. This is what we input, including other pages on all of our patients that are listed for transplant. And they're hoping to go back and look and see who's dying on the wait list, and can we create a continuous score that's going to describe who should be prioritized for transplant. I'm going to finish up here just the last couple of minutes talking about our transplant program. So we're located in the Bronx. The Bronx is about 1.4 million residents, so actually a large area on its own. And the demographics are different than other parts of the city and other parts of the country. It's 56% Hispanic, 29% Black, less than 9% white. And importantly, the Bronx is actually the poorest congressional district in all of the United States. And the household poverty rate is 26%. And we are actually leaning into this. These are the patients that we take care of. They represent the region around us. If you look at our wait list registrations, 50% are African-American, 20% are Latino. And if you look at the national averages here, it's about 27% versus 50, and 19 versus 11. So we're really sticking to our local population. And we are what is generally considered a medium to large transplant program. These are the transplant volumes year over year. Last year, we did slightly less transplants, but this year we're on pace to do about 40. That is where we think our sweet spot is. And when we do this, we do it really well. These are data that came out in January. Every 6 months, the Scientific Registry of Transplant Recipients gives a report. These are our survivals from January, 96.3%, much better than expected, with a hazard ratio that's almost half. If you look at that based on the characteristics of the patients we transplanted. This is another way to look at it. Each little circle is an individual transplant program in the country. You go left to right is transplant volume. Up is people that have done worse than expected, down is people that have done better than expected. You can see we're one of the few programs in the bottom right quadrant. And if you go to SRTR and you click on 1-year transplant survival, you'll see that we come in as one of the top 10 transplant programs in the country, with other notable centers as Vanderbilt and Mass General. We do similarly well on dual organ transplants with heart kidney, heart liver, heart lung. And with that, I'm going to stop. The first heart transplant in the world was a xenotransplant. And despite exceptional outcomes with human heart transplant, there's a severe shortage of donor organs. And xenotransplantation offers a solution for donor shortage, and it might be in the near future. So with that, I'm going to stop and say thank you. And that's it. Happy to take any questions.
Congratulations, Dana.
Thank you.
Last, why is that converted balloon pump and LM? After the discussion we just had, why is it the same category? I mean, shouldn't indirect balloon pump be lower because that provides better cardiac output and more complications? So
Yeah.
it probably should be higher than indirect balloon.
Yeah, I mean, I think that's one of the nuances when they first created this new system. And certainly over the last couple of years, I think that's come to light more, that the balloon pump is a much more forgiving device, but probably offers less support. And hopefully the next iteration of that that will be corrected.
Great talk, Dana. So a question, you mentioned you talk about a 250,000 patient that has advanced heart failure in the US. This therapy transplant for about 4,000 patients, and xenotransplantation is really far away. What other therapies that exist or methods that currently exist can bridge this gap? It seems like over 95% of the patients are not getting adequate care.
Yeah, I mean, excellent question. I think the answer in 2024 is LVAD. We have a great therapy that's shown mortality benefit. I think that if you were a 48-year-old male, you would probably take transplant first, but otherwise, I think that, for those that don't have an option, LVAD is a great option. It has mortality benefit. It's shown quality of life benefit. There's no question. And probably one of the biggest questions that we have in the field is, why has the uptick been so slow in it, right? It seems like there's a lot more patients that could benefit from it.
Right, as always in house, the questions that related to that, as I showed yesterday, the zero-sum game, France on LVAD, we're still only doing 6,500. The question, are there really 250,000 people there, or even there are 100,000?
Yeah.
Where are they? Why are they not making it to our academic center? It's always been a question to Abbott, right?
Wow.
For LVAD. And I just don't, do you think these are people that are dying in ICUs in Idaho? They just don't have access to a center close by, or what's going on here? I mean, it's a huge question to ask, because it's gonna take a lot of how the LVAD field moves forward.
Yeah.
You have some more ideas into that?
Yeah, I mean, I think it's a tough question that we're all trying to answer. I mean, I have some thoughts. I think that there's probably more. I think that there's underdiagnosis of cardiogenic shock in ICUs. They get treated as septic shock. Sometimes we don't recognize when patients are failing as an outpatient in heart failure and when they should be referred early before they get too sick. And I mean, I would also put it back to you guys, Mass. I mean, I think that, you've been, Dr. Yordi and Dr. Goldstein have been thought leaders in this field for, 20 years now.
I think there are 40,000.
Yeah.
That's my number.
Yeah.
But amazing lecture. I do want to challenge one thing.
Yeah.
I hadn't thought about it before, but that's why I'm here, right?
Yeah.
This is a heart meeting.
Yeah.
You mentioned the kidney. I think in cost effectiveness.
Yeah.
I believe that heart xenotransplant is not going to happen.
Mm-hmm.
I believe kidney xeno is going to happen and is much more important. And I believe it will save a lot of money. Not having people to go on dialysis and then have all the mobilities that develop when you're on dialysis.
And I think that that's a very reasonable comment. I think that I agree with the second part that kidney will happen first. There are some techniques of doing chimerism where you can integrate self-epitopes into these clones. So maybe you don't even need immunosuppression. And for somebody that's on dialysis and we can wait 6 months to grow a pig organ, that's a great option for somebody on dialysis. And I think in all of solid organ transplant, if you look at it, everything happens to kidney first. We tested in people that have a backup of dialysis before it gets to heart. So I wouldn't be surprised that we start seeing clinical trials in kidney first. The process gets a little bit more involved before we get to heart, though.
Well, let me ask you a question from the perspective of a less educated cardiologist who doesn't have no training heart failure, specifically about to manage a lot of heart failure in his family. And I'm sure that many people attending here is in the same boat. When is too early to send you for evaluation and when is too late?
Our approach is it's never too early to send us. We are happy, especially with any of our colleagues in the area to co-manage. We're not looking to steal any patients, but I think that there's been some nuance in the management of heart failure over the last 10, 15 years between genetic testing, phenotyping these patients with cardiac MRI, up-titration clinics that I talked about yesterday that aren't really taking over the management of the patient, but this may be steering to the big picture and at least being plugged in that way, we can kind of get a sense of when they're going off the tilt. So that's my personal opinion. I think too late is obviously when they have end organ damage, but yeah.
I agree with that. Since you're an imager, Dr. Garcia is our chief, famous imager, when the patient has an ejection fraction of less than 20% or an LVET of more than 6.5, that is a simple MonteHeart rule. At that point, we would like a mandatory heart failure concept just to get to know these patients.
I may not point yet to the mention of the ejection fraction. There is anything on that.
Stay away from that. There was cervix in heart. Thanks again. I was the medical director of the transplant, but it's really an incredible team. And the physicians and our nurse practitioners, and Stefan Bernard is our chief nurse practitioner for transplant. And she has really made major contribution, I think, to our success, big time. And I think, again, your lecture will probably speak for itself and where you are as a leader in transplantation.
Thank you so much, Dr. Yordi, for such a kind introduction. And I also want to thank Dr. Goldstein for sitting through what he would consider a boring post-transplant talk instead of leaving to beat Long Island traffic out to the Hamptons. So I'm going to talk about something I'm very passionate about. This is post-transplant monitoring without doing biopsies and how we can use this blood test to reduce malignancy risk in the post-transplant patients. So as Snehal mentioned, the first human-to-human heart transplant was performed in 1967. And the early heart transplants were really plagued with high rates of rejection and infection, and the outcomes were very poor. And this is actually a newspaper article of the
first transplant patient who died 18 days post-transplant from a pneumonia. So really in the 60s and 70s, nobody was really using heart transplant as a therapy for refractory end-stage heart failure because of the poor outcomes, until around the 1980s with the introduction of cyclosporin. And you can see, like, over the past 70 years, the development of immunosuppression has been vast. So this is showing the volume of transplants. And again, in around 1983, you can see the large uptick in the volume of transplants after the introduction of cyclosporin. And as Snehal mentioned, in the US alone in 2023, we performed about 4,500 heart transplants. And with the development of these immunosuppressive therapies, there has been reduced rates of rejection post-transplant. So this is showing between 2010 and 2016, between discharge and 1-year follow-up post-transplant, rates of rejection are around 12.6%. So immunosuppression, it does work. This is showing that, again, around the time of the 1980s, with the introduction of cyclosporin, you see a large increase in the median survival post-transplant. And as time goes on and newer therapies such as tacrolimus, CellCept, sirolimus, rituximab are introduced, that the median survival only improves. We have a current 1-year survival of 90% for transplant as a whole, almost 99% if you get your transplant at MonteHeart, and a median survival of around 12 to 13 years. So really, because of these immunosuppressive therapies, heart transplant is the gold standard for the treatment of end-stage heart failure today. So I just want to give a little overview of the different phases of immunosuppression for people that don't normally take care of transplant patients. So we have 3 phases: induction, maintenance, and rejection. And induction is the first immediately post-op or intra-op. You're giving these really high, intense doses of immunosuppression at the time of transplant. And this is to prevent hyperacute and acute rejection. Then what the patient's on for the rest of their lives is maintenance immunosuppression. And this is to prevent acute and chronic rejection. Most patients are on a 3-drug regimen that consists of a calcineurin inhibitor, an antimetabolite, and tapering doses of corticosteroids. And then when patients have transplant rejection, we give them higher doses of immunosuppression to acutely treat the rejection. So in the beginning, after the transplant, we're giving the highest doses, and it's really a standardized approach where we're tapering these medications down according to a protocol for time post-transplant. So really all of the patients are kind of getting the same, most of the patients are getting the same therapy, and it's just tapered down according to time post-transplant. So there's really a delicate balance with immunosuppression, where we're trying to modulate the patient's immune system to prevent rejection, while avoiding the adverse effects of over-immunosuppressing the patient, which include infections, toxicity, and what we're going to talk about today, which is malignancies. So it's this constant seesaw of a balance that we're dealing with on a daily basis with our patients. So this is a quick question. At 5 years post-transplant, so for patients who survive to 5 years post-transplant, what percentage of heart transplant patients develop at least one malignancy? Is it 0 to 5%, 5 to 10%, 15 to 20%, or greater than 50%? Okay, good. So everyone says about 5 to 10% of patients develop a malignancy at 5 years post-transplant. So back to my slides here. So this is data on post-transplant malignancy rates in survivors of transplants. So here at 5 years post-transplant, there's actually a 16% of malignancy. So if a patient survives to 5 years, they have a chance of developing at least one malignancy. And then again, at 10 years, if they survive to 10 years, they have a 30%, almost a 30% chance of developing at least one malignancy. So you can see below that skin cancer is really the highest incidence because of the photosensitivity that comes along with some of the immunosuppressants that they take. And then other cancers that we usually think of, such as lymphoma, the more common cancers like breast cancer, lung cancer, colon cancer, the rates are actually pretty similar to those of non-transplant patients. However, when a transplant patient gets one of these cancers, they present much more aggressively and they develop a lot more rapidly. So as coordinators, we take it very serious for our patients at each follow-up visit to make sure that they're staying up to date on all of their cancer screenings. They're seeing dermatologists every year. They're going for their mammograms. They're going for pap smears, routine colonoscopies, because early detection is really key. And here we're showing that malignancy is a leading cause of death after 5 years post-transplant. So once you get to around 5 years, it's the second leading cause of death after graft failure, and it accounts for around 25% of all deaths once you reach 5 years post-transplant. And this only gets worse once you get even further out, and once you near 10 years, it actually becomes the leading cause of death. So why do we need novel biomarkers to help us with this? So a couple of the presenters during MonteHeart have spoken about this New York Times piece of transplant patient Amy Silverstein. She was a 2-time transplant recipient who eventually died from metastatic lung cancer. And what she said in her article is organ transplantation is mired in stagnant science and antiquated, imprecise medicine that fails patients and organ donors. So really, our transplant programs in general are judged on their 1-year survival and 3-year survival. And there's really no motivation for long-term survival. What about the 5-year and 10-year survival? The last major development in immunosuppression was tacrolimus, which was almost 20 years ago. So we really need something new. And the field is really churning towards how can we give the patients a better long-term quality of life and better long-term survival. One size does not fit all when it comes to immunosuppression. Our current approach to immunosuppression is very reactive. We're treating rejections when they're found, and we just reduce the drugs if there's no evidence of rejection. And it's just tapered according to time post-transplant. So what's our goal for the future? We want to move from the system of protocolized immunosuppression to a more precision immunosuppression with individualized risk analysis. And how can we do that? So the liquid biopsy, I gave a talk on this last year, but I want to give a quick overview of what it is. So HeartCare testing it's a peripheral blood test that's used to assess rejection of the transplant. And we're combining gene expression profiling, or AlloMap testing, and donor-derived cell-free DNA, or AlloSure testing. So instead of the traditional biopsy that we used to perform on our patients, now all we have to do is a simple 3 tubes of blood. We send it off to the lab. We get a result about 2 to 3 days later that can tell us whether the patient is having graft rejection or not. So it's much less invasive. You have improved patient satisfaction, early detection of rejection, and you don't have the inter-observer variability that you get with a pathologist looking at the biopsy sample. So at MonteHeart, in the past 5 years, we've gone from doing 14 post-transplant biopsies to now only 4 post-transplant biopsies for our patients. So it's really been great for our patients. It makes them really happy. So just to break this test down into 2 pieces, AlloMap quantifies the expression of 11 genes that are altered during cellular rejection. The score is really associated with activity of the recipient's immune system. So a lower score shows that there's a quiescent graft. There's limitations of this test. It's not developed to detect AMR. It cannot detect injury to the graft, and it's steroid responsive, so we can't use it in the first 2 months post-transplant. And years after AlloMap was developed, we actually have AlloSure, which is donor-derived cell-free DNA testing. So when our cells go through normal apoptosis and necrosis and normal cell death, we're releasing cell-free DNA into our plasma. So what this test is able to do is that with any tissue damage to the graft, this is releasing the donor's DNA into the blood. And so this test is able to calculate the fraction of the DNA that's donor-derived versus the recipient's own cell-free DNA. So So any rejection to the heart would cause injury to the cells of the heart and would cause the release of the donor's DNA into the blood, which is what we're measuring in this blood test. So how can we use this test to mitigate malignancy risk in our patients? So there's very little data on this, but I'm going to share two abstracts that were published. So this was from the University of Iowa, and it was a retrospective study of 116 patients, and 21% of these patients developed a malignancy, at least one malignancy post-transplant, with a median follow-up of 5.5 years. So this is pretty similar to the statistics that I showed earlier. And what this is showing on the left there, so our early first AlloMap that was taken 1 year post-transplant, if this AlloMap was less than 20, the patients had a 25% chance of developing a malignancy, versus the patients who had an AlloMap of greater than 20, they had a 7.5% chance of developing a malignancy. And then 1 year post-transplant, they checked with an AlloMap score of less than 22. Those patients had a 100% chance of developing a malignancy, as opposed to the group of an AlloMap greater than 22 had a 28% chance of developing a malignancy. So again, this is a small group of patients from one center. And this is another abstract from the same center that was presented at ATC last year in 2023. And they're looking at a similar population. Instead of an AlloMap score of 20, they're looking at a little higher AlloMap score. This is a mean AlloMap score of less than 27. And what they saw is that the patients that had an average AlloMap score of less than 27, 1 year post-transplant, they had a almost 40% chance of developing a malignancy, as opposed to those with an AlloMap score of greater than 27 who had a 20% chance. So again, this is just an abstract, but it's showing that the low AlloMap scores, maybe when we see a low AlloMap score, we can consider pulling back on some of the patient's immunosuppression. So this is a case of one of our patients and how we use this testing to mitigate their malignancy risk, and how we use it in this patient to prevent the development of PTLD. So AW, he's a 52-year-old male. He had a heart transplant in March of 2021. He was EBV high risk, so the donor was positive and he was negative. He presented to the clinic in June of 2021, so 3 months post-transplant, with headache, difficulty swallowing, and a high temperature. And at the time, he had an EBV viral load of around 9,000. We pan-CT'd him to check for lymphadenopathy because we were concerned for the development of this post-transplant lymphoma. And it was negative for any lymphadenopathy, and we treated him for mononucleosis. So what is PTLD? It's a type of lymphoma that can develop in people who have had a transplant. Most cases are related to the infection with the Epstein-Barr virus. After exposure, it can stay in our body, and if it's not kept under control, such as in patients with a transplant, it can cause uncontrolled B-cell proliferation. So really the first line treatment for this is reducing the immunosuppression as much as possible to prevent this EBV viral load from going up and from the patient developing PTLD. So and this is a little bit of a busy slide, but I'm going to walk you through it. So here in June of 2021, again, this is when he first presented to us 3 months after the transplant with the symptoms, and the CAT scan was negative. And at that time, you can see in July of 2021, he was on a tacrolimus goal of around 11 to 13. He was off of Cellcept, which usually at this point, patients are on a dose of 1,000 milligrams twice a day. And he was on 3 milligrams of prednisone. So at this time, he did have an AlloMap of 37, which is slightly over our cutoff of 35. And he had a negative AlloSure, which was reassuring that there was no injury to the graft. And he did have the EBV viral load of around 9,000. So what we wanted to do was reduce the immunosuppression as much as possible, even more so than we already did. So at 5 months post-transplant, we lowered the patient's tacrolimus goal to around 8 to 10, and we kept him on very low dose of Cellcept. So this is a lowering of tacrolimus that we would normally do at around 6 months post-transplant. So it's done a little early. And the patient, again, the AlloMap was negative. The AlloSure was also negative. So it was reassuring that the patient wasn't having any rejection. But as you can see on the side there, as the time went on, the patient still was spiking. It was stable, but still had some of an EBV viral load. So we were monitoring this closely, and at 7 months post-transplant, we lowered the patient's tacrolimus goal to around 5 to 7. So this is a really early reduction in the goal of tacrolimus. This is something we usually do at 12 months post-transplant. And he was completely off of CellCept, and he was on a very low dose of prednisone. Again, he had a negative AlloMap and a negative AlloSure. And then we wanted to monitor from here to make sure that he wasn't having any rejection. So you can see the next couple of months, he continued to have negative AlloSure, so we were very reassured. And then at 1 year post-transplant, he still has this viral load of around 8,000. So we lowered him, we took him off of all other immunosuppression, and we kept him on monotherapy tacrolimus, which I probably have only 3 patients out of the 400 patients that we follow that are on a monotherapy, and a lower target of 4 to 5. So even on this very minimal immunosuppression, he had negative AlloSures, which was extremely reassuring that the patient wasn't rejecting, and we're able to mitigate this risk of him developing PTLD. So fast forward a year later, in August of 2023, we did a full body PET scan on this patient just for monitoring, and he had no lymphadenopathy. He continues to have like stable EBV viral loads, but he's not having any rejection on these very low doses of immunosuppression. So the question could be that why are his AlloMaps so high? So his AlloMaps were high, but his AlloSure was low. What does that mean? So there's new data from the recent SHORE publication that indicates that the risk of acute cellular rejection is very low with discordant heart care results. So the low AlloSure is telling us that there's no injury to the graft, but the high AlloMap might indicate that his immune system is reactivating. So this high AlloMap plus the low AlloSure, in this case, it was probably telling us that this patient does have some kind of infection going on. In this case was the EBV. However, it was reassuring that there was no damage being done to the graft. So we clearly need more data on this, and this is a mosaic trial that we hope to participate in the next coming year or so. It's going to be the first randomized control trial to investigate guided immunosuppression optimization versus standard of care. And at week 4, the patients will be randomized. At week 8, we're going to reduce the tacrolimus goal to 8 to 10, which again is something that's usually done at 6 months post-transplant. And at week 12, they will try to reduce the tacrolimus to a goal of 6 to 8, which is usually done really 5 to 7 goal at 1 year post-transplant. So this is something that's really exciting that we're hopefully looking forward to participating in. And to conclude, so immunosuppression has developed over the last 70 years, allowing for improved post-transplant survival. However, long-term survival is plagued by malignancy and other complications related to the immunosuppression. So we have embraced gene expression profiling in cell-free DNA as a tool to monitor rejection and reduce invasive procedures for our patients, but we look to use them as tools to minimize immunosuppression with the hopes of reducing malignancy rates in our patients in the future. And this is a picture of our team in Prague. And I know MonteHeart is a time for us to share knowledge and to educate each other and to talk about what we do here at Montefiore. But I just want to acknowledge the team here and say that I'm honored every day to come to work and work with this team. And it's a true, all these people in this picture and a lot of people in this room are the reason that we have such amazing outcomes. So thank you, everybody.
You can point out that I'm not in the picture because I'm standing in the door, I think.
Probably.
Yeah, I was counting earlier.
With that,
Christian, excellent talk. Question, being that malignancy is highest about 5 years, how far out are you monitoring your patients with heart care?
So we don't really have a standardized approach for our patients right now. After a year post-transplant, it kind of depends on which attending is taking care of the patients. But we really like to monitor at least twice a year heart care testing in our patients once they reach 1 year post-transplant. And it's a little bit easier for our newer patients now that we have a baseline on them. Sometimes if you start doing heart care testing once the patient's already 5 years out from transplant, it becomes a little difficult when you don't have a baseline immediately post-transplant.
Christiana, thanks for a really terrific talk. I don't have a question. I just wanted to thank you for really the superior care that you give all our patients and your leadership with the nurse practitioners, transplant coordinators, and just everybody on the team. So just thank you for everybody.
Thank you so much. Thank you. Oh, you don't need a mic, Sasha.
So Christiana, but the question is now, can we do it even better? Because Ultra or LMAP, they're reactive. Things already happened. Mobility damage, cell-free DNA is really the cell focus. The DNA is really this, there's some cells dying and everything else. What can we do? Because especially from the side trial, I'm like, we will increase immunosuppression and then we'll monitor the develop rejection. Or we have really the targeted immunological therapy. We need to see something before. Are our immunosuppression good enough for things like that? Is there anything we can do or?
I think that you can also take a look at your patient and see whether they're a higher or lower immunological risk. It all depends, like I said, one size doesn't fit all. I don't know if Snail can also comment on this, but I think, if we know that a patient is maybe a woman who has had multiple pregnancies, who's African-American, they're at higher risk for rejection. This is something that maybe we would want to be more careful doing, as opposed to somebody else who's less immunological risk.
It's a really good example. We had a patient with an African-American multivirus, BK virus, a dual organ transplant, which makes using the ultra difficult. And we use like old technology, like immuno, to try to target like very low immunosuppression. So I think we just need to maybe expand and all on the authority, which is this, and better targetation.
I think that's a really good question. I guess the test that would be the holy grail would be, can we figure out how immunosuppress the patient is? We have one test for that. And we can hope for that it can work. And some of the data that's interesting from the abstracts that you presented is that AlloMap is a loose correlation of immune activation, right? So the patients with low AlloMap scores, meaning they were very immunosuppressed, are more likely to develop malignancy. And I think that's something that we need to look at to move on.
No, this question.
Excellent presentation. Regarding the use of AlloMap in AlloSure, for example, we're going to start with cell-free DNA. Do you think we need the AlloMap, the gene expression profile, on top of that? How do we use this? You presented a good example. Basically, we're looking more at cell-free DNA in order to reduce expression. So do you think we can do it without the AlloMap gene expression?
I think if you're using it for post-transplant, immediately post-transplant monitoring for rejection, that cell-free DNA is kind of like the way to go. I would say you didn't need AlloMap, but I think this is kind of showing that AlloMap could potentially be a really good tool in telling you how immunosuppressed your patient is. So maybe you could use it for other things rather than, if I had to make the choice, I would take an AlloSure any day and get rid of the AlloMap. But I think this is showing really promising use of the AlloMap in the future.
Last question.
Yeah, hi. Thank you for your talk. Patients who have cardiac risk factors, like abdominal, like RCD, big cardiac fat, same patients have malignancy risk factors, same. Is there we are working on to try to reduce these markers like adiposity, abdominal, and epicardium, because they also are conducive to malignancy. So I think that is one aspect we need to also look at.
Yeah, I don't know. I don't think we're looking at that.
We are very careful on post-transplant patients with all this risk factor modification. Most of the patients have the best blood pressure, diabetes, obesity. But Cristiano's actually been very aggressive about getting all of our patients onto GLP-1 for weight as well. So I think it's a good plan.
Thank you.
Amazing. Thanks so much.
I think with everyone also battle, I have to say I give everything I had yesterday. So I don't have much to but my solution to our case, transplant or other is it depends.
Yeah.
After listening to Snell.
I agree. It just took the opportunity to put together, I think, what we basically go through every Wednesday morning when we try to figure out what should somebody get, and I think maybe this is kind of unnecessary that you could go through all of this. But the point is, we have a patient with heart replacement therapy, and the ultimate goal is we're probably going to offer them transplant. But if they meet any of these factors, they're not a transplant candidate, they have a high chance of recovery, they have high-risk features or biological disadvantages that makes the wait time long, we're going to move to LVAD first. So we really think that these are complementary therapies.
Great, thanks. So we stay in Thai, I think.
Yeah.
Okay, good. All right, next speaker is Shivank Madan. Shivank is also one of the faculty. He's also the medical director of research, overall research for the entire division of cardiology for the past, I think, 2 or 3 years, and he's done an incredible job revamping that. But Shivank is really a leader in donor research and expanding the donor pools. And even now the opportunity to present all the papers, which are incredible. So thank you, man.
Thank you, Dr. Yuri. So it's almost lunchtime, so I'll try to keep it short and quick. So the topic that I was assigned was expanding the donor pool with new technologies. I have no conflict of interest to disclose, but I will be discussing some investigational use of certain medical devices. Now, the prevalence of heart failure in the US has been on the rise. It is estimated that in the year 2020, there were about 6.7 million patients with heart failure in the US. And this number is expected to increase to 8.5 million by the year 2030. Okay. Now, keeping that 6.7 million number in mind, now we had a brief discussion regarding this in the previous talk. So let's just do a small thought experiment. So there were 6.7 million patients with heart failure in the year 2020. Now, if you look at the literature, various studies, epidemiological studies have estimated that any given time, about 5 to 10% of all the heart failure patients are in an advanced heart failure state. So if we use that percentage, that gives us about 300 to 600,000 patients anywhere who are supposed to be in advanced heart failure in the year 2020. Well, what happened the following year, 2021? Only about 6,000 of these patients ended up receiving a heart replacement therapy. So that gives us the number that only 1 to 2% of all the advanced heart failure patients in the US end up receiving a heart replacement therapy. Now, some of you can argue there may be slight variations, but definitely not the number of heart replacement therapies that we should be offering to our patients in US. And a big reason for that is the problem of donor shortage. All right, so let's see how many of you are paying attention to Dr. Patel's talk. So that's the first question. Let's see. Okay. So of every 100 donors available for heart transplantation in the US, approximately how many are eventually accepted? The options are 30 out of 100, 50 out of 100, 60, or 70 out of 100. I think we can lock the poll. Okay, so that's good. Everyone was paying attention to the talk. That's good. All right. So let's see. Okay. All right. So the interesting part is that the number of donors in the US has actually gone up in the last 25 years, from about 5,000 in the mid-90s to now more than 10,000 donors in recent years. But the number of heart transplants have not gone up at the same pace as indicated by this green line. And that gives us this huge gap in the use of donors for heart transplantation. In fact, the donor utilization rates have gone down from about 45% in the mid-90s to just over 30% in more recent years. So that gives us the right answer, which most of you got it, that only 30 out of 100 hearts offered are actually used for transplantation. And the problem of donor shortage has captured a lot of media coverage and has grabbed a lot of public attention over many decades, because it has been such a pressing problem. So during this talk, what I'll try to do is I'll try to highlight the challenges that we have faced in the field of heart transplant and how the advances in technology and medicine has helped us to face and overcome those challenges. So let's look at the first problem, the problem of donors with hepatitis C virus. Now, historically, there have been poor heart transplantation outcomes for recipients of hearts with HCV positive donor hearts, as indicated by which everyone in the field is very well versed, that indicated by increased mortality and increased cardiac allograft vasculopathy. And cardiac allograft vasculopathy is basically coronary artery disease in the transplant recipients. So I showed you that the outcomes of transplantations from HCV donors were poor. But on the flip side, what's happening in the US is that there has been an opioid epidemic. So the number of HCV donors that have become available has continued to go up in the last 20, 25 years. And because of poor outcomes, these donors were not used for transplantation. In fact, between the years 2006 to 2014, 0 HCV donors were used for heart transplant in the US. But then what happened in the new era? As I said, that there's an ongoing opioid epidemic leading to increased drug intoxication deaths and increase in number of HCV donors. There was development of direct-acting antivirals that you could now start treating chronic HCV virus infections. The NAT testing became available that you could differentiate between donors. We could potentially test the donors and then figure out whether they are viremic versus non-viremic. And most of the transplant societies recommended that to consider NAT-negative donors as non-infectious. And all these factors placed a re-emphasis on the use of donors with hepatitis C virus. Now, this was a study from our group, now was published a couple of years ago, led by Dr. Patel. And what I want you to pay attention here is that after a donor gets infected or any patient who gets infected with hepatitis C virus, there is development of viremia, there is seroconversion, but about 1 in 4 donors would spontaneously clear the virus, and 3 out of 4 will continue to have chronic viral carriers. And this allows us to distinguish all the HCV donors into HCV non-viremic and HCV viremic. And we went on to publish our center's experience of the 14 HCV non-viremic heart transplantation, where basically we showed that all these patients survived up to 6 months without even needing any therapy. Well, in the following study, we went a step ahead. We used a large database where we looked at more than 200 heart transplantations from donors with hepatitis C virus. And this is what we found, that there was no difference in 1-year mortality in the new era between hepatitis C virus versus non-hepatitis C virus heart transplantation. So I showed you that in the new era with direct-acting antivirals and NAT testing, the mortality is good. I mean, there's no increased mortality. So, but what about secondary outcomes? do secondary outcomes for heart transplantation from HCV donors, did they improve? Well, this was a study again from our group where we looked at secondary outcomes at 1 year for heart transplantation with HCV donors. And basically what we found that there was no differences in terms of cardiac allograft vasculopathy or secondary outcomes, indicating that the use of HCV donors is safe. So that brings me to the second question. Let's see. All right. So with the availability of direct-acting antivirals, NAT testing, and good outcomes of heart transplantations from HCV donors, did the usage of HCV donors increase? Your options are yes, it increased from 1% to 10%. No, it remains at low, 1%. It went up from 1% to 25, 30%, or from 1 to 5%. All right, I think we have a lot of responses. Okay, so that's the correct answer. It went up from 25 to 30%. So this was a study again from our group where basically we looked at the utilization rates of adult HCV donors in the new era. And what we showed was that the use of HCV donors in the new era went up from about 1% in 2015 to over 25% in a matter of few years, approaching that usage of donors without hepatitis C. And the success of all the data that I showed you was the use of HCV donors in single organ transplantation. And we also noted, again, this is a different study from our group, where basically we looked at the use of HCV donors for multi-organ heart transplantation. And the success was translated to this as well. The usage went up from like 0% to 14%. So again, a problem identified and solved. All right, so let's look at now the next problem, the problem of donor hearts with left ventricular systolic dysfunction. Now, it's important to use new technologies, but I think it's also important to make appropriate use of the existing tools that we have. So I'll show you how. So donor left ventricular systolic dysfunction, or in simple terms, poor heart function, is accounts for about 20% of the non-use of potential donors. And is one of the major reasons why we turn down these donors. Now, this was a study from a transplant center in California, very elegant study where they took about 13 donors with left ventricular systolic dysfunction and repeated their echocardiograms during the donor management. That's basically the donor is brain dead, is in a hospital, that's a terminal hospitalization, and then the repeated echocardiogram during that hospitalization. And what they noted, interestingly, was that the median ejection fraction went up from 41% to 56% in a short time. Now, using these two data points as the base knowledge, this was a study from our group now a couple of years ago, where basically we identified donors who had an echocardiogram repeated for various reasons. And then from those, we identified donors with those who had left ventricular systolic dysfunction, which we defined as ejection fraction of less than 40% that improved to more than 50% during the donor evaluation. And we looked at their outcomes. And interestingly enough, we noted that such donors where the LV dysfunction was improving, they had good post-transplant outcomes up to 5 years of follow-up in terms of post-transplant mortality, graft vasculopathy, or primary graft failure. And based on this, we came up with this algorithm, and I think it is something that we widely use and is also used pretty widely, where basically donor left ventricular systolic dysfunction is probably a manifestation of a brain-heart connection. So what's happening in a brain-dead donor is that brain injury leads to catecholamine surge, and there is a sympathetic storm. That is followed by a catecholamine depletion and receptor desensitization, which leads to reduction in the vascular tone. There is reduction in myocardial contractility, leading to left ventricular systolic dysfunction. And what we proposed was that centers should do donor optimization that includes repeating hormones, catecholamine repletion, and should repeat the echocardiogram within 12 to 24 hours. And if the ejection fraction is improving, then it is okay to accept the donor heart. And this is something that even our practice has used very successfully over the last couple of years. All right, so coming to the next problem, the problem of donor heart transport. Now, during standard donor heart transport, we are always running against time. So this is an article from the year 1978, basically which describes long distance transportation of human hearts for transplantation. And I'll read the highlighted part. On May 9th, 1977, a donor heart became available in city 1,094 kilometers from Richmond, that's Richmond, Virginia. Simultaneous excision of the donor heart and kidneys was performed. The donor heart was immersed in a 4-degree solution of saline, packed in a plastic bag and transported by a chartered jet to Richmond. The article goes on to describe how they successfully transplanted 6 adult hearts using this long-distance transportation, where the mean distance travel was about 482 miles. And that has been the real limitation of our field, that distance of 500 miles, which has been so difficult to break the barrier. So how are we transporting these organs in the year 2020? So basically the same method. We would take, it is an ice cooler, literally an ice cooler, which has ice. And then it has a series of plastic bags, which contain preservation fluid. And inside that is the donor heart. We procure the organ, and then we run to the airport, take the plane, and run to the transplant center. Now, there's been some advantages, right? This is a simple method, even though it involves a jet. Trust me, it is a relatively cheaper method, and it is reproducible. All centers can do it, but there are problems associated, right? It leads to time-dependent ischemia injury. You get cold injury because there is direct contact of the organ with the ice, and it put limitations to the organ sharing. Well, so this is the one of the newer devices for controlled hypothermic static storage, where basically you take the donor heart after retrieval, and that is placed in a pressurized canister, which has the preservation fluid, and then it's put in this storage device. And the advantage of this is that it offers uniform cooling of the donor heart, and you can tightly regulate the temperatures between 4 to 8 degrees Celsius, right? So this is offering 2 advantages. One is you're getting the advantage of hypothermia-mediated reduction in metabolic activity, and it prevents cold injury because there is no direct contact with the ice. And the studies have shown this to be have a lot of promising early outcomes. In fact, we have started using this device in our practice very routinely. All right, so I showed you the advantages of hypothermia for preserving donor hearts, that you reduce, you slow the cellular metabolism and you reduce the ischemic cascade. But what if we could also continuously perfuse the donor heart, either with the donor blood or some other solution? You can maintain the patency of the blood vessels. You can minimize endothelial injury. You can give nutrients to the organ when you're transporting, and you can probably even remove metabolic toxins. But why not, is it not that the combination of hypothermia and perfusion is probably a better approach? So this is a device called as the hypothermic ex vivo machine perfusion system for donor hearts. It's by the company that's named Ex Vivo. It's a Swedish company where basically you procure the donor heart, and then the donor aorta is cannulated, as indicated. This is indicated by the black arrow, and you place the donor organ chamber, donor heart into the organ chamber, and that is perfused by the perfusion pump. Okay, all right. So there are some advantages to it, right? You are allowing continuous perfusion of the donor heart with a cardioplegic solution that is supplemented with nutrients and hormones. It contains some RBCs, and it is allowing you to achieve coronary perfusion. The results of using this device in trial were recently presented earlier this year. This is still an investigational device in the US. There's an ongoing randomized controlled trial called Ex Vivo Preserve, which MonteHeart is going to participate in as well. All right, so I showed you previously hypothermic. Now, this is the normothermic ex vivo machine perfusion system for donor hearts, also popularly called as a heart in the box, where basically after procuring a donor heart, it's cannulated, placed in this box and cannulated. And what it allows is a continuous perfusion of the donor heart at near physiological state. You're trying to mimic the body's physiological state in an ex vivo perfusion. The goal being minimizing organ ischemia during transport. This has an aortic line that you can use to perfuse the aorta and using that the coronaries of the donor heart. Then it has a pulmonary artery line, which is basically letting you drain the blood from the coronary sinus into the right ventricle and then into the PA line. And it also lets you have an LV vent via the left atrium that you can make sure that the LV is empty. And this device lets you monitor a ton of things. You can monitor the aortic pressure of the heart, the coronary and the aortic flow, the oxygen saturation. You can control the blood temperature. We can draw and check lactate levels to make sure that the organ is doing fine. And you can even pace the heart at your desired rate. And currently, this is the only FDA-approved device using for ex vivo machine perfusion system in the US. All right. So lastly, I wanted to highlight the recent developments that have happened in the field regarding DBD versus DCD transplantation. Now, in heart transplantation, traditionally, all the donors have been brain-dead donors, where basically you have a patient who has a severe brain injury, meets the brain death criteria, as Dr. Patel showed earlier. There is declaration of death and then becomes a DBD donor. Now, there have been several advantages, and this is how we have done transplant for many decades, is that the donor heart is still in the donor. So there is no organ ischemia. And you can use various testing to check the function of the donor heart, like echocardiogram and other testing. But with donation after circulatory death is a different pathway. Here, a patient does not meet a brain death criteria, but has an irreversible brain injury and is not expected to survive withdrawal of life support. And then there is consent for organ donation. We then followed by withdrawal of life support, a cardiopulmonary arrest. There is a standoff period. And finally, there is declaration of death. And then this potential donors becomes an actual DCD donor. Now, there are some challenges with using such donors. Whenever the donor undergoes a cardiopulmonary arrest that leads to warm ischemia, that is organ injury, and once the donor heart stops contracting, it's in a standstill, there was no good way for us to tell whether this heart is going to be safe for transplantation or not, whether it's going to work if we use this heart and transplant it into a patient. And again, this is what was happening, that before the year 2019 in the US, almost 100% of the adult heart transplants were using brain-dead donors and 0% using DCD donors. Now, this was a study from our group, basically where, again, highlighting the mechanism that a donor undergoes withdrawal of life support, there is circulatory death, mandatory warm ischemia, and after that, the donor heart is retrieved, and you either place it on an ex vivo machine perfusion system that I just showed you, or these donors undergo normothermic regional perfusion which I think Dr. Forrest is going to talk about more in detail, where you try to restart the donor circulation without starting their blood flow to the brain. And if the heart is of okay quality, then we can use it. In fact, we go on to show that the early US experience of DCD heart transplantation was as good as the DBD heart transplantation. And I think from this study in Jack, this was probably the most important figure, where we showed that the trend of DCD donors overall in the US has been on the rise. And important, as I said, like before 2019, we were using 0 of these donors. And I think with these new technologies of ex vivo machine perfusion and normothermic regional perfusion, the expectation is that in the coming years, as many as 10 to 30% of the heart transplantations in the US are going to be from DCD donors. And with that, thank you.
That's terrific, and really, you all have to appreciate that all the papers around is really defined behind those papers, and has influenced care throughout the country for sure and the world. So we'll close out with 2 surgeons to have a small debate. The first speaker is Mayuko Uehara, who is earlier on the panel. And what they're going to discuss is how we can preserve the heart in the world in 38-year-old potential only one and cannot 35 years. And the United Discussion of the various treatments.
Hi, in this session, there is some overlap, but in this session, I will talk about organ donation with catastrophic brain injury focused on organ care system transmedics. So as Dr. Madan talked in previous session, there are 2 ways for organ donation. The DVD donation after brain death, which is a traditional pathway for organ donation, and DCD donation after cardiac death, which is relatively new pathway started to expand the donor pool. So it is considered that DCD will increase heart transplant 10 to 25%, and then decrease the waiting time. However, especially for the heart, DCD needs to be supported by new technologies. So OCS, organ care system, accompanied by transmedics, or NRP using ECMO, followed by stable cooling technology device, accompanied by Paragonics. So in traditional DBD, we are able to examine the heart function in the donor body like this. And the final decision to accept heart or not is based on this visualization. However, in DCD, since we have to wait to open chest until heart stops, so we cannot visualize the heart function. So let me talk about DCD heart procurement process. So DCD donors have severe brain injury, but they are not brain dead. So systemic heparin is given before starting the process of declining the donor's life. The donor will be extubated either in PACU or, and then we will wait until donor expires in different room. So we wait 5 more minutes to make sure, and then enter the OR to start procurement. So to use transmedics OCS device, we need to collect 1.5 liter of blood through the right atrium. Then we do cross-clamp, start cardioplasia. Once cardioplasia is done, heart will be harvested as regular way. So in general DCD, the donor's blood pressure gradually drops after extubation. When systolic blood pressure less than 50, cardiomyocyte, when the becomes less than 50, the heart doesn't get enough oxygenated blood. The cardiomyocytes start to be exposed to warm ischemia, which called agonal phase. So we further need to wait until the donor expires and then wait 5 more minutes. So starting from agonal phase until cross-clamp and start cardioplasia, the cardiomyocyte exposed to warm ischemia. And then after we start cardioprasia, so we put on the ice on the heart, and then heart finally getting cold. So, and then because the cardiomyocyte is known if it is a very delicate ischemic stress, so ideal warm ischemic time is known that less than 30 minutes. So once the heart is harvested successfully, the heart is placed into the OCS transmedics machine. So this is how heart looks like in the OCS machine. We can visualize heart function directly in the machine. And then there is a monitor which shows EKG, pressure, coronary flow, etc. So we can draw blood from here and then check lactate, other metabolic stuff. So this is a blood reservoir, and then oxygenated blood goes to ascending aorta and then flow to coronary artery. So one of benefit using OCS device is that we can assess the heart movement and the metabolism over time. So this is a very rare case, but the heart was assessed for 3 hours. So heart was big, lactate remained high in 40 minutes, and then 3 hours. So both LV and RV looked dysfunction, even 3 hours after perfusion time. So we declined this heart. So let's review DCD heart on OCS device fate. The heart graft warm ischemia until cardioprasia starts, and then goes cold ischemia when starting cardioprasia until heart is out from donor body, and then placed into the OCS transmedics device. So once heart is placed in transmedics machine, heart gets warm and perfused, and then start to beating again in the machine. So during the transportation. So when arriving the heart into the recipient OR and then ready for implant, heart is cooled down in the machine, arrested, and then take out the machine from the machine and then bring it to the recipient chest, and then stay cooled until finishing all anastomosis, and then cross clamp off. So the heart is exposed warm ischemia, cold ischemia, and warm perfusion, and then cold ischemia again. So this might be one of disadvantage using OCS device. So since heart is exposed to much stress, a bit worried about the outcome. So I think there's no published data comparing between DCD OCS and DCD NRP outcome. However, I think Dr. Madan talked, but accumulating results showed not much difference between DCD and DBD outcomes. So in 2022, Dr. Alessandro published the data from 47 DCD and 167 DBD heart transplantation at MGH. They said waiting time for DCD heart was shorter than DBD. And then even though there was trend for primary graft dysfunction, ECMO and RV dysfunction for short term, all improved in 4 weeks, and then 30 days and 1 year mortality showed no difference between groups. So this is our DCD heart transplant case. The donor was 36 years old with BMI 35 and asthma. The patient became agonal phase 2 minutes after excubation. But systolic blood pressure slightly went up again, more than 50. And then first agonal phase was ignored. And then agonal phase started again 12 minutes after excubation. And the decline of this was 8 minutes after second agonal phase. And the cross clamp was 5 minutes after skin incision. And then warm ischemic time was 14 minutes. The heart was harvested and placed into the OCS machine. Function looked good, and we brought this heart to Montefiore. The recipient is 67 years old, blood type O, 5 to 10 height, with ischemic cardiomyopathy on home milrinone. The history of cabbage in 2022, and this cirrhotic due to long-standing RV dysfunction, but cleared by hepatology. He has been listed for heart transplant, but required admission for worsening hemodynamics, and then balloon pump was placed, and then listed as status 2. So at this time, he agreed to accept Hep C donor and DCD donor. Then he got offered this DCD heart 8 days after accepting DCD donor. So this is intra-op TEE image which showed excellent transplanted heart function. So DCD heart with OCS transmedics machine went success, and he discharged home 28 after transplant. Thank you.
Just want to add that Dr. O'Hara is really exceptional surgeon, donor surgeon, ECMO surgeon, has also multiple research awards from the Society of Thoracic Surgeons, so a real super member of the team. And he goes to first. All right. Dr. Forrest, this microphone is going to warm up. Forrest is the director of cardiac surgery, also director of the lung transplant program. And he's going to speak to us, lung transplant program very successful this year. He's going to speak to us about DCD NRP, which is the kind of the twist on DCD, so there's a lot of discussion in the past 2 years.
All right, thank you very much. Yeah, it's sort of funny. I mean, for me to debate Mayuko and the best procurement strategy for DCD is sort of ironic, considering I've only procured DBDs in my era. And so people like Dr. O'Hara, as Uli mentioned, she's really an expert in donor procurement. And she's been at the ground level and really helped evolve this field and all these devices. It's really amazing to just take it face on and really get amazing results. And so everything I present here is just from reading the textbooks and talking to Mayuko. And so there's no debates. Whatever she tells me is the best way to go get the heart. So a lot of this, Dr. Madan is shown us. But when we talk about having a patient who's a DCD donor, there's a lot of variables prior to the DCD we can't control, involving the warm ischemia time, the agonal phase, and everything leading up to the declaration of brain death. But as we have already alluded to, we have a couple options what to do with that organ, and how we can procure it, the best way to assess it, and the best way to get it back for the best results in the recipient. And so if we're trying to debate which is the best system or the best approach to procuring these organs, we have to talk about how are we going to assess the organ. As Dr. O'Hara mentioned, we have the ex situ evaluation, utilizing the organ care system or transmedic system. But when we talk about NRP or normal thermic regional perfusion, we have the ability to have an evaluation of the organ in situ. And specifically when we talk about thoracic transplantation, we like to talk about thoracoabdominal NRP, which is where we're reperfusing the rest of the body, which is contrary to just abdominal NRP, where we are only perfusing the abdominal organs. And here we see in the picture to the right side of the slide is just a heart pump or an ECMO circuit that we use to reperfuse. And this is a transportable circuit, or if the donor comes to the institute where they are procuring, we would utilize to reperfuse the patient. Now, in terms of TA-NRP, this is the example where where after the patient is declared dead, there's a standoff period where the patient is then cannulated with drainage from the right atrium, and the blood goes into that circuit that I just displayed, where the blood is oxygenated, returned via the aorta to prevent reperfusion of the brain. You can see in this picture a cross-clamp application across the head vessels to prevent reperfusion of the brain, which has a lot of ethical concerns, which is not the discussion of this talk, but is the technique that we use for TA-NRP. In the case of just abdominal reperfusion, a clamp is applied to the aorta and the groin will be cannulated, leaving the thoracic organs ischemic or available for just a direct procurement strategy. Now, interesting, I sort of have already misused some of the terms, but I think it's important when we discuss NRP last year, where the American Society of Transplant Surgeons released this as part of their guidelines when talking about DCD, that terminology such as reanimation, resuscitation, should be avoided when discussing NRP, particularly in patients outside or in caregivers outside of the sort of transplant world may have some misnomers and misconceptions about what we're doing to the patient after they're declared dead. And so we have to be careful with how we describe this. And even in the literature up until the prior year uses a lot of these terminologies. So I think moving forward, it's something that we're going to have to keep in mind and change sort of the nomenclature and how we describe what's happening to the patients, because it is more emotionally tied to when you're thinking about reperfusing the rest of the body. And so I think in situ tissue perfusion is an accurate term that they describe here. So the benefits of NRP is that we have the ability to assess the graft within the donor body. It allows us to give a visual inspection. Most importantly, it allows us to wean and volume fill the heart. We get to see the heart acting in a normal physiologic state where we can introduce blood. We wean the patient off of the ECMO circuit, and we see how it functions. Simultaneously, we can provide hemodynamic monitoring with central venous pressure, if available, pulmonary artery pressures. Though this is plus or minus depending, obviously, on the donor hospital, and TE or transthoracic echo or intraoperative echocardiogram may be a tool that we can utilize when assessing the graft in vivo. Though, as you may or may not know, obviously procuring around the country, a lot of these tools may be limited depending on the donor hospital. Now, this slide just shows an experience from Vanderbilt with one of the larger experiences in DCD donation. They predominantly use NRP as their means of procuring DCD hearts, and they are comparing it to the gold standard DBD, where we see in the blue line DCD organs showing very similar 1-year survival, graft dysfunction, and 1-year treated rejection, showing that NRP is in fact a very successful and adequate tool to procure when comparing to our DBD recipients. And this is a publication from this year looking at an update in our UNOS and national experience, where we see similar outcomes in patients who have DCD NRP, which is in the red, and direct organ procurement with organ reperfusion, which is seen in the blue. And so it's tough to debate at the end of the day. Both techniques are excellent techniques and yield excellent results. It's just a matter of how we want to evaluate the organ in or outside the body. Now, when talking about our two options, you have to consider cost. At the end of the day, there are costs of the devices, there's costs of the teams, and an organ recovery cost may incur additional fees when you talk about the different devices, such as the Transmedics, which may be around $45,000 for disposables and around $250 for the device in itself. But in looking forward, can we decrease our post-transplant hospitalizations, length of stay, ICU time to sort of compensate those costs? And looking at this analysis published earlier in this year, where we have in the left column in the highlighted red box, we have NRP comparing to a direct procurement with machine reperfusion. You see that NRP yields a higher net income in this very small series, again, of 21 patients. And so from the terms of being cost effective, NRP does appear to have a leg up when we talk about which is the best way to pursue a DCD procurement. Now, the disadvantages of NRP are that it is logistically challenging. It does require a surgeon, a competent co-surgeon. You have the perfusion team to run the ECMO circuit, and you have to have an anesthesiologist who is rather active on site, potentially requiring echocardiogram and reanimation of the heart and additional time in the operating while we're evaluating the heart. There are ethical concerns, which is a conversation itself with reanimating, reperfusing the organ. And of note, there is a shorter period of functional assessment, meaning that with the transmedics, you have the availability of following the lactate, following the coronary pressure, seeing how the LV and the RV recovered. Though it is an unloaded state, you do have a longer time to reassess the heart. And importantly, once we accept the heart, in the case of NRP, we do procure it in a sort of standard situation, arrest the heart, and you do succumb to a longer cold ischemia time while it is outside of the body. Advantages of NRP, as I mentioned, you have a functional assessment of the loaded heart. You minimize ischemic insult to the abdominal organs and the lung, meaning that you do reperfuse all the organs. You give the abdominal team a little bit more time, and they're less subject to ischemic injury to the liver. And so there is a benefit from the whole team approach of procuring these organs using the NRP technique. As I mentioned, there's cost and timing advantages to using NRP as well. Dr. Madan has already sort of described the technology that we're using after the heart is procured in a NRP situation, that rather than transporting it in cold ice storage, we are using the Paragonix Sherpa pack, which maintains the organ at a 48 degrees centigrade, suspending the cold heart solution, preventing it from that the injury that it would succumb to being maintained in an ice storage system. And just briefly, we see here in an updated publication showing that the red line is using the Sherpa pack, that we are seeing a non-significant but divergence of curves in patients who have a static cold storage device with a slight increase in survival, though again not significant. And finally, when we look at patients who are using static cold storage versus ice, there is a blip in the data showing that there is less severe primary dysfunction, particularly in the patients who have a LVAD at the time of transplantation. I think that regardless of what we use, we have to have these techniques to continue maintaining this increase in volume of heart transplantations. And so both tools are adequate, and depending on different clinical scenarios, both NRP and the OCS are both excellent tools depending on certain clinical scenarios. And I think that we have to be open-minded to these technologies, and there really is no winner or loser to this debate, but rather just options. Thank you.
Thanks, Steve. Thanks, Steve, for the great talk. While I was listening to your talk, I was thinking that I don't want to call it ECMO, but heart-lung bypass machine has been there for, correct me if I'm like 50 years or more than that. So is there a reason why we as a field did not think of NRP 20 years ago? That the ex vivo machine perfusion systems are the ones that came now, and then we are trying to find an alternative. But now that I was listening, we should have probably thought of it 20 years ago. I don't know, your comments.
Yeah, that's pretty deep for the last talk at 1 p.m. So no, I think honestly, the way that the field works and the way that surgeons work are, if it's not broke, don't fix it. And so I don't think there was an incentive previously. You had great success. We're approaching, greater than 90% survival. And I think introducing a variable that is more time, more money, potentially more complications, which we're encountering with other procuring teams. I think that was probably the fear. But now that we have a need, I think we have to open our eyes and change the field a little bit.
Yeah, a good answer to that question. NRP was invented in Spain for the abdominal retrieval of organs. And that has been going on for 20 years. So then it evolved to abdominal retrieval, and that was Stephen too, who actually started the first retrieval with NRP in 2000, because originally they started doing transplants, but place and he said, why don't we do NRP? Just, go a little bit further up. And that's how we started in Spain. We learned from Stephen Tui, who I can guarantee is probably the person who knows most about ECG transplant in the world.
And when you started NRP for the abdomen, there was no clamping of the head vessels.
No, what we do is we implant an intra-aortic balloon pump, but just move the aorta. We don't clamp the head vessels when they do abdominal NRP.
Why did the abdominal team start? Why did they start NRP? Why did they?
Because the results were much better than when we just secured the liver for the kidneys directly. Like the results when they did fast succession, they just took them out and put them in ice. Those ones were bad. They didn't have the machines then. They didn't have the machines or perfumes. Transmedics are now they use for lungs, for livers. They have their own perfusion system. So that is why they use this to and then assess. You can have NRP. You can have the patient there for 2 hours. The liver people actually monitor the lactate and see how they evolve over at least 2 hours. They need more than 2 hours to see how the liver is doing. So, and we actually do that. We do the NRP, we let the heart beat, then we take away the NRP. So we actually clamp the system and then just, obviously have to intubate the patient again, you have to ventilate the patient, and then it's like a DVD, then it just becomes DVD, and extraction is just like DVD.
Maybe just one last question, just now that we use Sherpa Pack all the time, what happens if they move to
I have no idea where they went, but it's funny.
Beers to the Hampton is.
Yes. Great. Thanks, Steve. Mayuko, great presentation. I just want to thank one more time all the speakers, the whole team, audiovisual team, CME team, our team in the office. I'm really filled with pride what our team has put on here in the past 2 days. It's been amazing. It's a beautiful day outside, 80 degrees, sunshine. So we're going to finish up here. Next year's meeting will be on June 5 and 6. 2025. So we'll send out emails about this at some point. But all of you and the 93 people on Zoom that also have nothing better to do, thanks for attending. It was really a very successful meeting for us, I think.
What?
Great job. Really fantastic.
Thank you for trusting
yes,
me with this.
Yes, no.
It was the first time, but it was good.
Yeah. And you have other actions, which is perfect.
I have all
so I want all of that next
You want all of them?
Yeah.
Except the
That's all right. Next week or something.
Yeah, except the brothers. He had some